for our second annual Oversight RN webinar. The target audience is Oversight RNs from residential provider agencies, and then, of course, any other stakeholders. This webinar will offer educational opportunities, a support system, and resources. And I will pull up the agenda here in a minute, but I just want to let you know, presentation topics are dignity of risk, the Missouri Quality Outcomes, or MoQuo and You, which is an excellent resource for us, enabled dental or teledentistry, oral health and hygiene, disaster preparedness, end-of-life planning, assistive technology. There will be an hour-long lunch break at 12 p.m. Please do not log out, but just mute yourself during this time if you can. Let's see, I will act as one of your hosts. My name is Leslie DeGroat, and I am an RN, and I'm the division's clinical coordinator. And members of our team who have made this possible and who will be speaking today, I would like to introduce Tricia Parker. She's an RN Community Health and Wellness Coordinator. Caitlin Bartley will be speaking with us today, and she has her master's in social work and is the Division National Core Indicator Project Coordinator. We also have Kaylee Graham, who is an RN and works for Enable Dental, and will be speaking to us about the project they have, as well as oral health and hygiene for people with intellectual and developmental disabilities. Monica Corba is an RN, and she will be joining us and will be speaking about hospice and palliative care. Michelle Cooper is an RN, and she works as a quality programs RN in the Springfield Regional Office. Ashley Mord, she's an RN and works as a quality programs RN at the Joplin Regional Office. Holly Reif will be joining us later, and she's one of the division's leads in provider relations as well as assistive technology. So she's going to help talk about how assistive technology can enhance the people we serve's lives, as well as Shannon Shores, who is a sales executive for Pack4You Inc. That company is contracted with a division to provide assistive technology services. And anyway, I would just like to thank all the people I just named for making this possible, as well as Kat for helping us with our presentation today. I'm now going to forward and show you the slide with this is tentative. You know, we may run a little early, may run a little behind, but this is what your day is going to be looking like if you're able to hang in there with us. And as Kat said, we are going to record this so that way people can watch it at a later date, or maybe rewatch it if there's something that you feel like you need to review or what have you. You know, it'll be available on our division's website, so you can kind of see there what the lineup of things. And if you need to step away and take a break or grab a cup of coffee, feel free to do so. Let's see. I'm just going to leave that up there just for a little bit so you can kind of look at it. Got a pretty full agenda. And I believe I'm going to see if our colleague Caitlin Bartley, oh, there she is. Hey, Kate. I'm honored to introduce one of my colleagues. She's our first presenter for the day. Her name is Caitlin Bartley. She does have her master's degree in social work from the University of Missouri-Columbia and is currently working on her doctorate degree. She serves as the division's National Core Indicator Project Coordinator, and she just does amazing work, and she's going to talk to us today about the dignity of risk for individuals who we serve, and also a resource that she has created called Missouri Quality Outcomes, or MoQuo and You. And I would now like to pass it over to Caitlin. So Kate, I'm going to share that little red folder here in just a second. Thank you so much for joining us today.
Awesome.
Yeah.
Yeah, thank you for having me. This is awesome. So I will share my screen. Let's see. Can you all see that?
I can see it.
Awesome. Well, thank you all for having me today. It's really awesome to be share with you all this first presentation that I was going to share with you. It is a presentation that I was asked to give last month, and I initially presented it to the University of Missouri School of Health Professions graduate students. So that I'm about to show you, I've presented to about 150 students in the respiratory therapy, 2202, social work, radiology, and ultrasound departments, as well as other departments in the School of Health Professions. That anyway, I have been asked to present this to kind of share my story and to give a perspective on person-centeredness. So I would like to start out with a discussion question, and you can answer it in the chat. If you could define yourself in 1 to 2 sentences, what would you say? And Leslie, I could not see the chat when I'm doing this, so let me know if anything comes up.
Okay, I certainly will. And I'm not seeing anything just yet.
Okay, well, if you could have even 1 or 2 people,
Oh, we have something here. Someone has put grandma to 2.
Aww.
And I'll just put in mine, I define myself, I suppose, I am a nurse and a mother and a wife, and I like to care and be around people, I guess.
That is awesome.
There's another one here, caregiver with priorities of God, family, then job.
That is so cool. Well, I do not want to spend too much time, so I'm going to go ahead and move on. But keep putting those answers in the chat if you want to. But something I did notice with y'all's responses is that none of you all listed any diagnoses and medical conditions. And you know, of course you didn't, because if you have any medical diagnoses, they don't define you. That's not who you are. So that is really important to remember when working with people with medical issues and disabilities. Their diagnoses are just a piece of who they are. So to share a little bit with you all, I have my bachelor's in psychology and social work. As Leslie mentioned, I got my MSW from the University of Missouri, where I am currently working on my PhD. I also, in the state of Missouri, employee, and I'm also a Christian. I'm a daughter, a sister, an auntie, a friend, a dog mom. I love the St. Louis Cardinals and the Kansas City Chiefs. And I'm a bit country music fan. And I just happen to have muscular dystrophy. That's just a piece of who I am. It's not who I am. So another discussion question. What do you all think the person-centered means?
Don't see anything in the chat, but I think it means it should be about the person who we're focusing on.
Yes. Yes.
Focusing, oh, we do have stuff. Oh, I'm sorry. Focusing on the whole person, not just the disability. It's about the client, all about them. Oh, thank you guys for putting answers, and I love this. It means care revolving around the person's wants and needs, catering to specific needs, wants for each individual, aware of the whole person at hand. Oh, these are excellent.
Yes, those are so awesome. Thank you for all of those responses, and all of those are spot on. So according to the National Center for Advancing Person-Centered Practices and Strategies, person-centered means to learn about the choices and interests that make up a person's idea of a good life, and to identify the supports needed to achieve that good life. And as you all probably know, person-centeredness is a concept that is used a lot within the disability service system. But it also applies to circumstances and settings that the people are in. So that may be schools, medical settings, social settings, and really just everyday life. And person-centeredness really emphasizes that it's not something that you do to or for a person. Instead, it's letting the person take the lead with support from facilitators as they need or right. And, you know, this can be kind of difficult. You know, it's human nature to want to look at someone with a disability who are really in minority status and make assumptions about who they are. So with person-centeredness, it's really important to try to recognize and minimize personal assumptions and to center care based on who the person is and what they need, want, and what their strengths are. So at this point, going to kind of transition and tell you all a little bit about my story, because so much of my life has been person-centered, and I think most of the people who have been the best influencers and supporters of my life, they're person-centered, but they didn't even realize that they were being person-centered. So anyway, I will share a little bit about my story. So first, we will talk a little bit about my medical stuff. As you all know, the medical model is very important. You know, you have to have the medical model to identify disease and disease processes, and then you have to have it to address those disease processes. However, with the medical model, the focus is on the defect and what needs to be fixed. And there is definitely a time and a place for that. You know, I wouldn't be here talking to you all today if I didn't believe in the medical model. However, it's also important to realize that a diagnosis is just one part of a person. In trying to fix the problem also has to be balanced out with the individual's quality of life. You know, all of us would probably have slightly different definitions of quality of life, and that's good. That's awesome because we're all different. However, one person cannot really define quality of life for another person. So I am, for example, going to share an example from my life. So as I said, I had muscular dystrophy, and with the type that I had, respiratory failure is a common characteristic of the diagnosis. So back in 2004, I was only 13 at the time, and my health was really starting to go downhill. I was sick a lot. I was having recurring pneumonias. I was in and out of the hospital a lot. I was also starting to have trouble with CO2 buildup in my system because I just didn't have the muscle strength to burn off the CO2, the carbon dioxide, like I was supposed to. So I was having issues with headaches because of that. Like I said, I had recurring pneumonias, and on Mother's Day, 2004, I went into the hospital with a pretty bad pneumonia. I was admitted to the ICU was put on by the cat. As you are nurses, I assume you know what BiPAP is. That is a type of external ventilation where they had, the mask that goes over the nose and mouth, and it swirls, and I absolutely hated that darn cell. It was so uncomfortable. I couldn't talk with it on, and it made me feel claustrophobic having that mask on my face all the time. So about a week and a half into that hospitalization, the doctors came and got my mom and took her out into the hallway, and they pretty much told her that we were to the point that we needed to make a decision. We could make the decision not to do anything, which if we did nothing, the CO2 buildup would eventually have an impact on my heart, and my heart would get out sooner than we wanted it to. The second option was to send the new home on BiPAP, or the third option was to go ahead and do a trach and a ventilator. And we got to the point that we had to do the trach and the vent, but I was probably heading in that direction anyway. So they told my mom to take some time to think about it and to let them know. Well, while they were out in the hallway talking about all this, I remember sitting in my hospital room thinking, what the heck? They are out there talking about me, and it's not about me without me. So when my mom came back in the room, I was like, okay, I know you all have been talking about me, and you all know to tell me what's going on. So my mom went back out into the hallway and told the doctors, we've been caught. She knows we've been talking about her. You need to come in and tell her exactly what you told me. So they did. They came in and they told me exactly what they told my mom. And my mom was like, I understand that you are only 13, but you have to make this decision. I cannot decide for another person what type of life-changing medical interventions that they want. So you need to make this decision. So, of course, I hated that BiPAP mask so much that I was like, hey, let's do it. Let's go to the OR right now and do the type and the vent. Of course, they were like, wait a minute, you still have pneumonia. You need to give you some time to get over that. But anyway, in that moment, I don't think my mom mom realized that she was being very person-centered by allowing me to make the decision. Also, it gave me the opportunity to advocate for myself and say that I wanted. And really, that is the best decision I have ever made for myself. For some people, a cut in the ventilator is something that's really sad, something that enhances quality of life. But in my case, the cut and the vent have totally improved my quality of life. I have not been as sick, nearly as often as I was before I made that decision. And I believe that the cut and the date is the reason why I'm still here and I'm still healthy enough to have a job and go to school and present to you all today. So that's just one example I like to share when I talk about person-centeredness. Also, my day-to-day life is very person-centered. It's very easy to try to put someone like me with all of my medical issues in a bubble. But you can't live life in a bubble. And I know very well that I need to do to keep myself healthy. But at the same time, I know how to balance that out with being a regular adult and living life. So that is a little bit of person-centeredness from a medical standpoint. Okay, another question for you all. What does inclusion mean to you?
Okay, we'll give them a chance to put in the chat. Making everyone a part of what is happening.
Yes.
Ooh, here we got. Ooh, we got some popping in. Okay, hang on. Okay, having the clients assist with activities that they enjoy. Making sure everyone is included and able to participate. Yes, all are welcome. I agree with that. I think it means like you're not turning anyone away. Anybody can show up to the party. That's what I think. See, having all of the same opportunities as everyone else.
Absolutely. Yes, all of those are so awesome. So I am going to use inclusion to transition into person-centeredness from an educational standpoint. So my education started very early on. I started attending the Special Learning Center at age 2. The Special Learning Center is a preschool here in Jefferson City for children with special needs. So I started there at age 2, and I was able to, not only get preschool education, but I also got the O2 tutor and speech therapy services that are needed. They also helped us set me up with my first notarized locator when I had just turned 12 years old. And also, when it came time for me to go to kindergarten, they helped with the transition from their services to public school services. So from kindergarten until I graduated high school, I attended South Calvary or 2, which is in Nottingham, Missouri. For those of you who don't know where Nottingham is, it's out in the middle of nowhere, about halfway between Jeff City and Herman. So it's a very small school district. However, they were extremely supportive of whatever I needed to be successful academically. I was always included in mainstream classes with my peers. I was never forced into a special education class. It was really important to them to teach me self-advocacy skills and to be able to speak up and say what I wanted and needed. So by high school, they had me running my own IE2 noodles, which I don't know if you all know. And IE2 is an individualized education plan. It's kind of like an individualized support plan, only within the school setting. They also helped a lot with getting me ready for college. They introduced me to vocational rehabilitation, who has helped a lot with all of the different degrees I had pursued. After high school, I attended Lincoln University here in Jefferson City, and I really wanted that college experience that everyone else had. So I lived on campus in a dorm. I had 24-hour nursing support, and I loved it. I loved having that freedom and independence, and I feel like that experience helped me grow up a lot. I also had the awesome opportunity to help make LU more accessible through the Women's Leadership Academy. I had to do a project that was going to make the campus better for other students. So I worked with the administration and with the buildings and grounds people, and when it was all said and done, they did some pretty drastic renovations to two of the main classroom buildings. them more wheelchair accessible. So it was really cool to be able to advocate for that and then to see those changes actually happen. Also, during my time at Lincoln, I couldn't decide between psychology and social work, so I decided to double major, and the psychology department was super supportive. They supported me to find a couple of internships, and they were just there whenever I needed them. However, I am going to consider a non-inclusive example with you all. Before I tell you about this though, I just want to say that this happened a long time ago, and it doesn't reflect Lincoln University as a whole. I love Lincoln, and it also does not reflect the LU social work program today. I hear messages that could bells about the current LU social work program, but I do share this experience because it is something that still happens way too often. So when you hit the bachelor's in social work, the final requirement is a field practicum, and it is the school's job to help you find a practicum that aligns with your interests. So I was so excited about this. I am a pretty enthusiastic, proactive person. So a couple semesters before the practicum, I was ready to start talking about it. Let's plan this. Let's figure out how we're going to do this. Well, my academic advisor did not share in my enthusiasm, and she actually told me not to have false hope about finding an internship because she didn't think that having my disability anyone would want to hire me. So, this was really difficult. I went through a couple of really tough days. Mentally, I was kind of in a dark and twisted place, questioning was I doing unrealistic? Was I asking too much? But after a couple days, it was like, this advisor does not have the right to tell me that I cannot do. Only I know that I am capable of. Also, it wasn't just about me. It was also about any student with a disability that can ask me. And And if I could predict this same situation from happening to someone else, I was going to do that. So I rocked this the Elder Disability Center, and they actually helped me to confront my advisor in a very respectful way, of course, that I was able to voice my opinions and tell her, you don't know me, you don't know my situation, and you can't decide for me if I can do an internship or not. So, of course, my academic advisor started backtracking. I was dramatizing, I was taking things out of context, blah, blah, blah. So, in the end, they decided to change me to a different academic advisor, and unfortunately, the next academic advisor did the same thing. She actually refused to help me find a practicum, and I wasn't allowed to find one on my own, unless they could find one for me, but yet they were refusing to. So again, I had to go through the LU Disability Center, and by that point, half of the university was behind me. The other half thought I was kind of a troublemaker. But eventually, it came down to they had to help me find a practicum, just like they did any other student. So they sent me to Missouri Coalition Against Domestic and Sexual Violence. That kind of frustrated me at first because I wasn't really interested in the BDSD field, but it turned out to be an amazing experience. I learned so much during that practicum. I learned some skills that I still use today in this job, and I successfully completed the practicum and my bachelor's in psychology and social work in 2015. And then I went right into the master's program. So I did my master's at Mizzou, and I concentrated on policy, planning, and administration. And the difference between the LU social work program and the MU social work program was like night and day. At MU, my disability was seen as a life experience rather than something that was going to stop me from hitting my master's. And then it came time to do my master's practicum. The discussion focused on what I needed to be successful rather than how my disability was going to make it impossible. So I started my MSW practicum this division in January 2017. I interned with the federal programs unit and learned so much about its CDS and about the different kinds of radars. So I completed my practicum that July, and I was immediately offered a position with the Quality Programs Unit, which is where I still am today. I don't know how much you all know about NCI, but NCI is a national project that helps state service systems measure and track system performance. So I am in charge of making sure that we meet NCI guidelines and benchmarks. I also help analyze the data for trends, and I help with stakeholder education. And so much of what I do centers on individual quality of life. So there is a concept called dignity of risk. And dignity of risk means we all have the right to make our own decisions, to accept the associated consequences, and to learn from our mistakes. For people with disabilities, though, the risk might be limited, and a lot of times it's limited by caregivers who work so hard to protect individuals that they don't realize that by doing that, they're actually diminishing choice. And choice is a part of life, and everyone needs the ability to make choices. Also, societal stereotypes also limit dignity of risk. So, dignity of risk is not about whether individuals with disabilities make dangerous or harmful decisions. It's about helping individuals to find that happy balance between safety and risk taking. Because, we all take risks every day, and we grow from the risks we take and the decisions we make. So individuals with disabilities should be supported to experience that also. So I am specifically interested in how service systems can better support individuals and their dignity of risk. So this led me to the decision to pursue my PhD in the School of Social Work. I wanted to pursue my PhD to oversight skills and to hopefully have more opportunities to contribute to dignity of risk research, because there is not enough research out there on this topic. So that is where I am at today. Just to wrap things up, if you take anything from this presentation, I hope it's that the person comes before the diagnosis. And it's so important to take the time to get to know the person, and that is important to them and for them. And also, sometimes the only thing you can do is to educate the patient about their health. You know, at the end of the day, the decision maker lies with the person unless they just have an intellectual disability that doesn't allow for that. But in most cases, the person is the decision maker. So it's important to educate them about the health so that they can make informed decisions to the best of their ability. It's always important to use person first language. So say you're, excuse me, person with a disability instead of disabled person. And it's always important to remember everyone needs choice. Choice is a basic human right. So it is just really important to be cognizant of how your choices may limit or enhance patient choice. And that is the end of my presentation. Does anyone have any questions?
I am looking at the chat, and it does look like we have about 5 minutes for questions. If anyone has anything they'd like to ask.
I am an open book, so you can pretty much ask me anything if you do have questions. If not, that's okay too.
You have comments, excellent information, and thank you. And another person said, not a question, but just wanted to say I loved what you said. It's not about me without me. And thank you, Caitlin. This was very inspiring. And there's more, all kinds of kudos. Awesome job, Caitlin. An awesome presentation. And thank you, Caitlin. You're inspirational. Good job. You're awesome. Great job. I personally think person-centered planning is the best thing. Everyone should have a choice. Oh my gosh, this is wonderful. Kate, you've inspired the whole group. I so appreciate you for spending time with us today. I'm kind of choking up too. That was really your personal experience and sharing and all the things that you've worked your tail off for, and you've, gotten through these obstacles, and you are very inspirational. And just thank you so much for sharing with us. It's yeah. You have so many good positive things. Your drive and determination are amazing. Thank you. That's another comment from the chat. Yeah.
Well, thank you all so much. I really appreciated it. Leslie, I don't think I had time to go over the no-kill and do reports, but would you still like me to drop the link to those
Oh,
in the chat?
certainly. Yes, that'd be great. You guys, Moko and you has so many different things, and there's some that's health-centered. It's just fantastic information. If you ever get a chance to just get on this link that Kate's going to share with us, and just feel free to look at that. And she just does amazing work. Does not have a medical background per se, but you would think she did just because she's just the way she put her documents together, especially the healthy living portion. It's super informative and just very good information.
Thank you. Thanks so much. So I am going to put that in the chat just so you don't know. Those reports are user-friendly documents that kind of help to show the result quality outcomes and into our data in a way that is fun and easy to look at and hopefully non-meaningful to individuals and families. I'm also sharing a link to the measured quality outcomes talking points series, which is a set of short videos that go along with the no-kill and do reports, and they are just, credited for individuals and families, and to explain the design quality outcomes in an easy to understand way. So please take a look at those. And if you have individuals and families that you feel could benefit from those, they are public resources, so feel free to share them however you like. And I think that is all I have, Leslie.
Sorry, I'm muted. I'm giving a big speech here. Kate, thank you so much for joining us today. Thank you. Your views and your research and just everything is so enlightening, and it's just so important to what we do to support people. And just thank you so much. We really appreciate you.
Thank you. I am gonna head off now, so you all have a good day.
Thank you, Kate. Have a great day too. Okay, let me pull up my PowerPoint and our next, I don't believe our next presenter is on just yet, which is just fine. Let me share my screen here in just a minute. Maybe I can't. Kat, can you hand me the red folder, please? I think it went right back to you. Oh, now I'm the presenter. Yay, thank you. Okay, share. All right. We'll give Kaylee just a minute or two. Make sure she hasn't tried to reach out with any technical difficulties. You know how that can be. Get over here. Okay. So just go ahead and have a quick break if you need to get up and grab a beverage or um, maybe do your thing while we're waiting.
Kaylee's on, and I just made her presenter.
Oh, she's awesome. Oh, right. Well, hello, Kaylee. Thank you so much. And I'm glad for you to be here today. And I would like to introduce you to our group. And before turning it over, um, Kaylee Graham is a registered nurse and received her degree from the Allegheny College of Maryland. She serves as the clinical project delivery coordinator for Enable Dental, which has a project that they have enacted in connection with the Missouri Developmental Disabilities Council and the Missouri Coalition for Oral Health to increase access to care for people with intellectual and developmental disabilities. She is here to talk with us about that project as well as oral health and hygiene for people with intellectual and developmental disabilities. And I am just so pleased you're here. And I will now turn it over to you, Kaylee. So I'm going to stop sharing my screen.
Thanks for the introduction,
And
Leslie. I appreciate it.
yeah, well, thank you so much for being here. This is, hang on here. I'm kind of wonky. All right. I gotta give you this little red box with a folder thing. Okay, you should be able to present if you care to do so.
Yeah, absolutely. As Leslie said, my name's Kaylee. I'm an RN. I have worked in the IDD world for about a decade. Before working for Enable, I was just like most of the people on this call, probably. I was an RN in a local HCS and ICF community. So I commend all of you guys for what you do because it's hard work. Thank you for serving this population because they need advocates, and I truly feel like um, nurses are huge advocates for these individuals. I'm gonna go ahead and share my screen. So I want to talk to you guys about oral health education for you guys to improve outcomes for the individuals that you serve. So the objectives of this presentation include, oh, let me fix that. I double clicked a little too fast. Sorry, technical difficulties on my end.
No worries whatsoever. You're doing great.
Okay, can you guys see that? Can you see my screen?
I can see it.
Okay. So the objectives that I wanted to cover today include identifying barriers to accessing care for the IDD population, understanding risk factors for poor oral health. We're going to talk a little bit about oral health assessments and understanding interventions to improve oral health for the IDD population. So I wanted to start with a couple of facts. Data indicates that people with IDD have a higher prevalence of untreated cavities, gingivitis, and other oral diseases than the general population. Just to kind of put those numbers into perspective, there is about 7 million individuals in the US with IDD, and Missouri alone has about 816,000. That's a pretty big number. You guys are kind of a small rural community. So, fun question. I don't know if I can see the chat in the presenter view, but wanted to ask you guys, do we naturally lose our teeth as a result of aging? True or false?
I can help you. I can look at chat, Kaylee, and we have a
Sure.
false. And I'm going to throw my guess in. I think false.
Yes,
False,
yes.
false. Yeah, lots of
Awesome.
falses. Mm-hmm.
That is correct. You would be surprised how many people think that losing your teeth is a natural process of aging. It is not. Losing teeth occurs from a disease process. Wanted to share that. So moving right into physical and behavioral restrictions to accessing oral health care. Let's talk about the physical aspects. A lot of individuals with IDD have mobility issues. from wheelchairs to walkers to requiring Hoyer lifts to maybe even being bedbound. A lot of your traditional dental offices are not equipped for ADA accommodations. So that is definitely a very large barrier. Some of the other barriers that we see are communication barriers. As nurses working in this field, we know that sometimes when we communicate with our patients, it takes a different approach with every patient. One patient may have a hearing deficit and require you to have writing as a form of communication. Other individuals may have a speech impediment so that they understand what you're saying, but maybe it's hard to understand what they're saying. So, um, I don't think this just applies to dental. I think the communication barrier can apply to healthcare across the spectrum. That's why it's so important that we, as nurses, that we're ensuring that when we're sending patients to appointments, that they have a staff that is comfortable with them, that can help communicate. Because sometimes communication doesn't always come as natural to healthcare professionals when they're not familiar with the patient. So, definitely exploring all options to help facilitate patients to advocate for themselves via communication, whether that be just talking with the dentist or talking with the support staff or talking with the receptionist. Um, and then behavioral. We know that going to the dentist can be scary. I mean, even me myself, I'm not a huge fan of going to the dentist. It's still, I have a little bit of anxiety associated with it. And I think that those prevalences are higher in the IDD population as well. So maybe they're scared or they've had a traumatic experience. I feel like there's a lot of different aspects to that. Sensory. We know that when we go into healthcare facilities, they're typically colder than others. They have bright lights. There's a long wait, and all of those sensory things can kind of trigger some uncomfortable responses or emotions. Um, and then let's talk about what we can do to help these patients who have anxiety and fear related to dental services. A big one that I have really, really talked to nurses and communities about is desensitizing. Use social stories, exposure, maybe just getting in the car and driving to the place of service one time, but not necessarily getting out of the car. But then maybe next week we go in and we familiar ourselves with the waiting room, preparing them for those experiences. It could also be maybe watching a short video about what to expect at the dentist. Clear and appropriate communication, I think, is also very, very important for the IDD population. Just for an example, I was with a patient last week, and a lot of times the dentist will give an injection in the mouth to help with the numbing. Well, the dental assistant that was there was like, we're just gonna shoot you in your jaw, and the patient freaked out. They didn't understand what the nurse meant by we're going to shoot you in the jaw, which as a nurse, um, we really need to make sure that we're using clear, appropriate communication. We're going to give you an injection. This is what it's going to feel like. This is what it's going to look like. Because sometimes terms like shoot can be taken very literal. Other things we can do to help with anxiety and fear is just provide distraction. Maybe it's that patient needs the radio on while they're seeing the dentist, or maybe they need a TV screen in front of them to kind of provide some distraction. Guided imagery is also a great help, positive reinforcement, and then, of course, medication as a last resort. Let's talk about the non-physical restrictions to accessing oral health care. Um, I feel like a big piece of this is lack of education in regards to the needs for the IDD population for healthcare professionals. I know when I was in nursing school, um, I think I had like 3 slides on a PowerPoint in regards to caring for developmental and disability populations. That education is very similar to what I see dentists and hygienists come with. They don't have comprehensive education from their base knowledge about serving this population. There is a big movement to change that. So I'm seeing some great things happen in the education world to improve services. I know another barrier that's also faced is you have patients that need IV sedation, and there's just facilities either are unwilling to accommodate, or maybe that the hospital just isn't in network with their insurance. So there's a lot of red tape surrounding actually getting services. Um, Medicaid reimbursement is another piece of that. I do have some great news for y'all. The state of Missouri has recently increased their dental reimbursement rates for your individuals. So I'm really hoping that that increases the access to care. Wait times for appointments can be difficult as well. Um, Earlier, we talked about sensory issues, and having to sit still in a waiting room for 40 minutes to an hour and a half can be stressful as well. Travel times and appointments. I know that you guys probably understand this barrier. I would be curious to know how far you guys travel to get dental services for the individuals you serve. Maybe pop some of that information in the chat for me. I know I was at a location here in Texas. I'm from Texas, by the way, that serves HCS and ICF, and they told me that they drive 3 hours to find a dentist to see their patients.
Oh, we do have, one person said 2 hours for one of ours for sedation. And let's see, 1 minute. Well, that's good.
Oh, that's really good.
Yeah, that's awesome. Maximum 1 hour away, or max 1 hour away. I'm guessing that means maximum. To Jefferson City. Another one said Jefferson City too. Approximately 45 minutes, 1.5 to 2 hours for some, especially if need sedation. Yeah, some of our rural areas, we are underserved definitely with dental providers and people who can do that kind of thing with sedation. Let's see, Clinton to Springfield is 1.5 hours, and to Kansas City is 1.5 hours. So,
Okay, so it sounds like at least, I mean, on average, at least an hour, right?
yeah, yeah.
That's a lot of travel. Okay, so let's talk about the social benefits of a healthy mouth. A healthy smile gives confidence and influences every aspect of our social lives. Think about the first time you meet someone. What is the first thing you notice? You notice their smile, you notice their teeth. Um, Evidence has shown and data has shown that when nurses smile at their patients, they increase positive outcomes. It encourages patients to be compliant, and it also encourages, it fosters good relationships, right? And all of the things that we use our mouth for. We use it for speaking, we use it for smiling, and we use it for eating. So, super important. It is a very big part of our person, right? So let's talk a little bit about risk factors contributing to poor oral health. Chronic disease is a huge, huge piece of this. Everything from heart disease to diabetes. Evidence shows that patients who have diabetes have very poor oral health. A lot of times when blood sugar levels stay at a high level for extended times periods, it can impact the circulation to the gums. It builds a more acidic environment in the mouth, which also causes decay to the enamel. Seizures, if you have a patient who has epilepsy, they are more at risk for trauma to the mouth during seizures. Lots of different chronic diseases. We could probably talk all day. I think there's another slide we'll get to with some more specifics. Self-care deficit, I feel like, is another area. There are some individuals who just need a little bit more encouraging to remember to brush their teeth. Maybe they are unable to self-sufficiently brush their teeth. They may need hand over hand. So self-care deficit is a huge problem for the IDD population in regards to oral health. Polypharmacy is a big one. I mean, you can probably say that most of the patients you take care of at least take 4 to 6 routine medications. I've seen some upwards into the 20s. Then there's other behaviors that can increase your risk for poor oral health. Pocketing food is a big thing we see in the IDD population. When food sits in your mouth, there's no time for your saliva to dissipate that. So it causes, again, more acidic environments leading to decay. Self-injury. I myself have seen more than one patient who actually would poke themselves with different objects in the gum. They would try to pull their teeth out. Grinding is also more common in the IDD population. It can also be a side effect of medication. So, and then there's some disease processes where they actually like to eat objects that aren't appropriate for eating. It's called pica. I think I pronounced that correctly. So that can cause damage to the teeth and to the mouth as well. So, question number 2, you could throw this in the chat box for me too. At least one preventative dental visit within 3 years reduces the likelihood of ventilator-acquired pneumonia by what percent?
Okay, I'm watching the chat. This is a good question. I can't even I can't even think of what it would be. I'm gonna just throw mine in there. Oh, we have a B, 15%, B, B, let me see. Yeah, B, lots of B's. B, D,
Okay,
B.
yeah, awesome. Thanks, guys. So the answer is actually D, 22%. And let's talk about this for a minute. So when you go see the dentist and you get your teeth cleaned, they typically scrape, they remove tartar. It causes stimulation to the gum, so it increases blood flow, and it removes bacteria. And that is the key point to this. Anytime a patient is intubated, especially if it's an emergency or if there is trauma associated, think about it. That ET tube goes directly in their mouth and into their airway. So any bacteria that is in their mouth that goes will also go into their lungs. So healthy visits to the dentist can create less occurrences of ventilator acquired pneumonia. And I know with COVID, the IDD population is at a greater risk for adverse effects and poor outcomes due to COVID. So ensuring that your patients get their routine dental care can definitely guide them in a right direction if there is a hospitalization. So we talked a little bit about the connection between chronic disease and oral health already. The big one that I also want to talk about is aspiration pneumonia. It kind of connects back to the ventilator acquired pneumonia. Same concept here. When you have a large amount of bacteria in your mouth and you have and you aspirate your saliva, then that bacteria will grow in the lungs and cause pneumonia. So here again, super important that we're getting our routine and preventative care. Let's talk about medication side effects. Anticholinergics, they are a widely used class of meds and they cause dry mouth. Let's talk about why dry mouth increases your risk for decay. So saliva naturally helps create a normal pH environment in your mouth. When your mouth is dry, then bacteria will have a growth. And bacteria actually causes decay at a way more rapid rate than we would say plaque, right? But plaque and food particles harbor bacteria. So that's where the increase for decay comes there. Along with dry mouth, you have an increase for fungal infections and other mouth infections. Antipsychotics also cause dry mouth. They can cause excessive drooling, infections, ulcerations in the oral cavity, gum overgrowth, dental erosion. Another really big one is anti-seizure medications. They cause gum overgrowth as well. And can anybody tell me the most common seizure med that causes gum overgrowth? Any idea? Dilantin. Yes, Cindy, you are right.
Hey.
Dilantin. Yes, great. Glad to see you guys know your medications. So bisphosphonates is another class of drugs that we often see patients who have osteoporosis on. Um, I actually did not know this until coming over into a dental position, is that when patients take bisphosphonates, they are actually at a higher risk for osteonecrosis of the jaw, post-oral surgery or extraction. Does anybody, can you guys tell me a couple of examples of bisphosphonates? Prolia, yes. Fosamax, yes. Great job. You guys are on it. Um, So it's really important that a trend I've seen a lot is that those injections for Prolia or maybe those weekly medications are stored on a maybe a treatment MAR or not necessarily on a medication administration MAR. So I would say that, 15% of the medical records that I have seen on our end, um, I see the diagnosis of osteoporosis, but then I look at their med list and I don't see a treatment for that. But when I call and ask, a lot of times I'm told, oh, well, that's on the treatment record because it's only given every 6 months. So let's make sure that we have comprehensive med lists for the dentist to review because osteonecrosis is very painful. That is basically when the jaw gets infected and the bone dies. Um, so talking about system diseases, 90% of system diseases have oral manifestations, and this is just a few of them. Crohn's not only causes like inflammation of the bowel, but it causes inflammation of the gums. Oral lesions, Addison's disease can cause pigmentation changes. Diabetes, you can have gingivitis, taste dysfunction, fruity smelling breath, HIV, bleeding gums, pain, cancer, here again, lesions and masses. With patients with bulimia and anorexia, we see erosion of the teeth, often from excessive regurgitation. Liver disease, you can see tongue abnormalities. Now, to talk a little bit about oral health assessments. As a nurse, we get an admission or, we're doing a quarterly assessment and we typically do a head to toe assessment, right? Um, well, it's really important not to skip the mouth in that assessment. Questions you can ask yourself is, do they have loose teeth? Are they wearing any appliances? Do you see sores or lesions? What do the gums look like? Are the mucous membranes moist? Do they have pain? These are very great questions to be sending. Yeah, absolutely. I can send this PowerPoint out to Leslie. Oh, and then Leslie, you could probably disperse that, or is there an easier way to post this
I think
after
that
the meeting?
if you are okay with it, you can send it to me and then we can post it with this webinar if you're comfortable with that.
Yeah, for sure.
Okay, thanks. Yeah, this is great information. This is awesome. So, yeah, thank you for sharing with us.
No, for sure. So let's talk about loose teeth. Like, I never thought to do this until talking to a dentist a couple of years ago. But they were like, you have nonverbal, non-mobile patients. If it's safe, put a glove on and just gently touch their teeth. And just kind of press and wiggle. If the tooth is loose, that's not normal. Loose teeth can be a huge, huge problem, especially if they're aspirated. They can tear the lining of the stomach, they can tear um, the GI tract. So we definitely want to be on the lookout for loose teeth. In regards to appliances, I have gotten patients myself where I look in their mouth and everything looks normal. And then, a week or two later, the staff, they're like, oh, well, he has a top partial. And I'm like, oh my gosh, I didn't even see it. Like dentistry has evolved into things where sometimes it's hard. Like you don't see the silver or the metal like we used to 10, 15 years ago. They blend very well. So, and in regards to appliances, it's really important to take those appliances out and look at the gums underneath it. Um, and then, of course, mucous membranes. Are they dry? Are they moist? Things like that. Okay, so question number 3. Bones are stronger than teeth. True or false?
Not seeing anything. Oh, someone said false. True, false, false, false.
Okay, so most of you are right. It is false. Your teeth, your enamel is the strongest thing that your body has, which thought that was an amazing fact. I'm like, wow, my teeth are stronger than my bones. Who would have thought? So moving into some quick assessment pictures, you know, gingival hyperplasia, this is what dilantin causes. You will see very puffy, inflamed gums. The gum lines will be very high. And then this other picture is what osteonecrosis of the jaw looks like. You can see the arrows, and that brown pigmentation is that back tooth was extracted, and you can see where the bone is dying. Super painful. So here again, this is another assessment slide. The one on the right side is gingivitis. You can see that the gums are very red and inflamed and swollen. And then the other picture is healthy gums. They're pink, they're moist, you don't see any bleeding. And then I think most of you can probably tell a dry mouth versus a not dry mouth. One thing I never thought about was the cracking of the tongue. That is a huge indicator that someone is very severely dehydrated when they have cracking and drying of the tongue. Mucous membranes kind of tend to be the first ones to dry up, but if you see a tongue that looks cracked, we definitely probably need to get some oral fluids on board and or maybe even talk about some IV fluids. So this next slide talks about ulcers in the mouth, aka canker sores is what my mom always called them. But the ulcerations can occur anywhere. They can occur on the lips, on the top or bottom of the mouth, on inside of the cheeks, and they can be very painful. Candidus is this other picture, which is a fungal infection. If you ever had little ones, you probably heard it being called thrush. It is a fungal overgrowth, so very important to report that to your primary care physician and get that treated. It can be very painful. So another fun question, what year was the first toothbrush made?
This is a neat question. I'll look at chat.
19. Okay, I see 17.
Oh, did you get one? Okay. Um, what was the guess you got?
There's a bunch of them. They're
Yeah,
all kind
there's
of
some I
different.
see.
So.
Yeah, there's A, number 3, number 4, 1731, 1820, 1820.
So the first toothbrush was made in 1498. And the bristles were made from hogs, badgers, horsehair, things like that. I thought that was interesting. Um, Okay, so let's talk about some dental advancements. I really thought about what I wanted to present to you guys, and this was the categories that I found. So, SDF is called silver diamine fluoride. It is a topical solution. When applied to the decay, it will actually arrest and stop the decaying process. Now, it won't rebuild the tooth, but it will stop the decay from getting worse. Xylitol gum is pretty cool. It actually is a gum you can chew that prevents cavities and helps the mouth maintain a normal pH level. It can stimulate saliva production and strengthen the teeth. There is some amazing studies out there that show women who chew xylitol gum postpartum that their babies and their toddlers have less occurrence of cavities because when they kiss their children, they don't pass bacteria between the family. So that was a really cool statistic. Fluoride, application of fluoride continues to benefit through lifetime. I know as nurses and even as the general population, we're like, oh, only kids get fluoride treatment, but that's really more of a commercialized fact. Insurance just doesn't tend to pay for it for adults. I'm seeing some plans that are starting to pay for fluoride and SDF for the IDD population. I think that that is a huge benefit. And honestly, fluoride and SDF are not very expensive, but they do wonderful things for the patient. Iodine, just regular over the counter iodine that we are used to cleaning wounds with, guys. Um, you can rinse your mouth with it, or you can apply it with a Q-tip to the teeth. Um, and evidence is emerging that it actually kills the bacteria in the mouth. And it can prevent new cavities from occurring. There are some studies that are showing that it can cause some discoloration in the teeth. So I would definitely ask your dentist or your PCP for an order. I know when I was working in the group homes, I just kind of made it a quarterly thing. Like when I did my assessments, I'm like, okay, here's a Q-tip and some iodine. Like, let's get those back molars and help this mouth create a healthy pH. You actually don't have to dilute it at all. You can just use it straight. I probably would dilute it if you were going to rinse with it, just because the taste can be kind of unpleasant. Um, but here again, it can discolor the teeth. So just make sure that you have an order on file before you use it. It's really good for those patients who maybe don't tolerate dental treatments, or maybe someone who requires sedation and maybe they can only get that sedation once a year or once every other year. It can definitely decrease the occurrence of cavities. Um, Oral probiotics, which I did not even know were a thing until recently myself. It works just like the probiotics that we take for our stomach. It creates healthy bacteria in the mouth. It will provide your mouth with good bacteria while overcoming the bad bacteria. So an easy treatment, a daily medication that can help your oral health. So moving over to preventative care, twice yearly exams and cleanings are the best thing for everyone. General population, pediatrics, IDD. I do see more patients with IDD that require maybe a quarterly cleaning instead of a Q6 month cleaning. Brush and floss twice a day. Emphasize non-carcinogenic foods and beverages. Please advise caregivers, family members to not use sweets or sodas as a reward. Prevent and treat dry mouth appropriately. We have some aids for oral care. This picture on the bottom is a regular toothbrush that has a large rubber grip on it. If you have anyone who has any kind of muscle or spasticity problems, being able to have a larger grip can really help them perform their own oral health care. There is a mouth block on here. These are disposable. You can get these on Amazon. It can help your staff perform oral care, maybe on your patients that are a little less alert or unable to hold their mouth open. Maybe they're big clenchers. Moisturizing spray. There's all kinds of products out there. There's mouth lozenge. There's toothpaste. There's mouth rinse that can help treat dry mouth. And then, of course, floss. Flossing is hard. Having any kind of adaptive aid for that to where they can have a handle to hold while they floss their teeth is great. You can also explore power toothbrushes. They're super reasonably priced these days. I would encourage them for everybody. And then there's other adaptive toothbrushes out there as well. You can have curved handles, you can have weighted handles, smaller or larger designs based on the need of the oral cavity. So we can get creative there. Amazon has some great choices too. Okay, question 4. How many calories are in a tooth? And calories as in if you swallow a tooth, how many calories does it have?
Three or two, one, number three, lots of number
Okay.
threes, one number two.
Yes. Most of y'all are right. So an average tooth has about 36 calories when swallowed and digested.
What a funny question. I love
Isn't
it.
it? I thought they were fun. So I want to tell you guys a little bit. We're kind of ending the end part of the presentation. So I want to tell you a little about Enable Dental. Enable Dental is my employer. We are a mobile on-site dental provider, as in we bring equipment to your day habs, to your group homes, to your private residences. We see patients in their own environments. We do specialize in seeing at-risk populations, so geriatrics and patients with developmental disabilities. We really take treating the patient as a whole into consideration, thinking about the medical, the dental, and the behavioral needs. This picture right here is kind of just a general idea of what we look like. All of our equipment comes pre-packed in these big rolling Craftsman and Milwaukee toolboxes. We have portable suction, portable x-ray. We are in Kansas City, yes. So our teams in Missouri dispatch out of St. Louis and Kansas City on the Missouri side. We deliver a wide range of services from preventative care to treatments. So exams, x-rays, fillings, cleanings, extractions, dentures, night guards, bridges, crowns. We do everything. And very exciting news is we accept Medicaid. We are a Medicaid provider in Missouri. Most recently, we have partnered with the Missouri Coalition for Oral Health in implementing a pilot program. I don't know if you guys are familiar with the term teledentistry, but basically it's a fancy term for hygiene first. So we send a hygienist and a scribe and an assistant out to do exams and x-rays. And then the dentist reviews that information from the medical record remotely and then decides if there is a treatment, and then the dentist can come out and do the treatments. So our program goals with this pilot were to improve oral health outcomes, education, cost reduction, and data collection. This program was designed to enroll 125 individuals. The counties served are listed here. We are still taking patients for this program. We have also decided that as a company, we will continue to open our doors to Medicaid patients outside of the pilot. So there's two phases on the pilot. Phase one actually closes at the 1st of October in regards to data collection and reporting, but we will still see patients. But our phase two of data collection and kind of providing that advocacy for change in your state is going to start in January of 2023. That's kind of tentative. We will be serving the Kansas City side, or the Kansas City, Missouri area and surrounding counties. So I can definitely get more information out about that if you guys are interested. And that is about all I have. Here again, thanks for your time. Have really enjoyed speaking to you guys. Would happy to answer questions if anyone has them.
It looks like there might be a few questions, but we do have another speaker that we'd like to bring in before our
Okay.
lunch break. So what I'm thinking is we'll pull these questions from the chat and I'll get with you and we'll get those answered and posted with this webinar, if that sounds okay with you, Kaylee.
Yes, yes. That sounds wonderful. I can absolutely do that. And then Leslie, I'll get this slideshow over to you.
I appreciate it. And then we'll work together in the future as your as Enable Dental moves forward with helping us here in Missouri and with the pilot project. And we'll make sure and get that information out to you all. I'm really excited about this and your smashing presentation. Love it, love it. Thank you so much for your time.
Awesome. You guys were a great audience. Have a wonderful day.
You too, Kaylee. Thank you.
Okay, bye-bye.
Bye-bye. And I'm going to try to, I don't know if I can per se. Kat, can you help me grab that presenter folder, please? Oh, thank you. Excellent. Okay, maybe not. I think I messed up here. Let's see. Yeah, Kat, can you? I think I messed up moving the folder. If you don't mind moving it to me, or Kayla, or
Um,
oh, okay, it's on there. It's on my thing. Okay, all right. Ladies and gentlemen, we have another guest that's going to speak with us here right before lunch. And she has been one of my colleagues for a few years now. She has done just a massive amount of work surrounding disaster preparedness and work with the pandemic. You know, she had already started planting seeds of preparedness prior to, and she just her and her team just worked really hard to help Department of Mental Health get through, you know, all of the past 2 years that we had to experience together. I'm so honored that she's speaking with us today. Her name is Becky Gear. She has her master's of science degree in criminal justice from the University of Central Missouri, Warrensburg, and she currently serves as the Missouri Department of Mental Health's Director of Disaster Services. And right now, she's going to spend a little bit of time just talking with us about disaster preparedness. And Becky, I'm going to go ahead and hopefully get you the folder a little bit more easily than when I was trying to get it. So I'm going to
Totally
pass it on down to you. Okay.
Totally understand. You know, after 2.5 years of virtual, some days are just still easier than others. So I totally get it, Leslie.
It is just, yeah. All right. I'm making you presenter.
Awesome. Thank you. All right. I'm going to go ahead and pull up. Whoops, I'm stopping my video. Now I'm having the difficulties. Let's see here. All right, here we go. Let me share my screen. All right. So you should be seeing, hopefully, my screen, and it should be the PowerPoint. So if you can't see it, let me know, or let Leslie know, and she can holler, or somebody just come off mute and holler at me. Good afternoon, good morning. Okay, good. Good morning, everybody. I'm excited to be here with you today. Leslie asked me to come talk to you about personal preparedness, and I'm going to move through the basics of personal preparedness, and then at the end of this, I'm going to actually ask you to use your cell phones or your computer to answer some questions for me that I have kind of looming in my head to see what else I can do to help you. So to start, you notice it is National Preparedness Month for, I believe, one more day. Tomorrow is the end of the month, but September is always National Preparedness Month, so a great time to come talk to you about personal preparedness and why we do it. So to start with, we need to know what types of disasters we can face where we live, but also where we work. Sometimes those are not the same thing. So while I doubt you'll be hit with flying meatballs like this graphic, it does show us that anything at any time can happen. So some of the potential disasters that we need to prepare for in Missouri are on the screen here. And I know these aren't fun to think about, but being prepared for these at home will actually bring you some peace of mind for not only you, but also your family members, because you know that everybody is prepared and thinking about where to go, what to do, and we're going to walk through what that looks like. But these are just a small snippet of some of the things we see in Missouri: fires, floods, tornadoes. Those are probably the most common. Ice storms and other severe storms, power outages, earthquakes. I'm going to knock on some wood here. Plane crashes, terrorism. There's all sorts of potential for lots of different disasters in Missouri. So you might be asking yourself, well, whose responsibility is it to prepare? It's actually our responsibility to be prepared for disasters. Only 1% of our population are folks who are going to respond and help. So that tells us that there's 99% of our population who are relying upon 1% of individuals to come respond and help us. Perfect example is what's happening in Florida right now. You know, I'm a disaster nerd, so I was paying close attention to all the disaster stuff happening down there and the hurricanes. And I was actually just in Orlando last week, so it's really kind of gripped me with where I was and looking at it. And one of the counties there said, we're receiving phone call after phone call, people asking us to come help, that the water's rising in their house and they don't know what to do, but they can't get to them. And they said, we hated to tell them, but we told them, you're just going to have to hang on. So it's a perfect example of why we ourselves have to be prepared for anything. When we are not in hurricane times that I can use perfect examples, I like to show this picture. This is a family in Texas that were impacted by flooding in their house after another hurricane. They had a 2-story house and they had to move everything upstairs and live upstairs for several days before any help arrived. So they had to figure out how to eat up there, how to sleep up there, and try to move things that they wanted to save so that they wouldn't be damaged down below, all while having no power and no one coming to help them. So again, making sure we are prepared at home so that we can take care of ourselves. And this could happen while we are not at home. We might be at work. And so how do we do what we need to do for our family while we are doing something else? So what can you do? Well, being informed is really important, thinking about the different types of things that can happen. We can plan for the different types of events by thinking through what you would do for that type of event. So when something happens, like the hurricane, and you might be thinking, well, a hurricane's not going to impact me. No, but the flooding might, right? We get a lot of flooding in Missouri. So what are you going to do for that situation if that were to happen? Thinking through that vicarious rehearsal, if you will. We also want to think about the different types of events because what you do for a fire is going to be very different for what you do for an ice storm. You also can assemble a ready kit or a go bag, and that's something that contains items that you're going to need in the emergency. And I know a lot of our facilities actually have started creating those in the homes as well. So you can get kids involved in this. If you have kids, have them make their own kit. Have them put certain things in there that they enjoy as well. Then you're going to maintain that kit and that plan by practicing it, making sure your plan works, making sure everyone in your family knows it, making sure you check your kit every 6 months to update items so that you can rotate out the items that need to be updated. Like if you have a pack of tuna in there, you're going to want to rotate it out and put maybe a new pack of tuna in there. Excuse me. A good time to do this is when we change our clocks twice a year. So a lot of people say when you change your clocks, check your stocks. So when you change your clocks, you can check all of your go bag items and you can change your fire alarm batteries at that time as well. Lastly, the other thing I would tell you is getting involved with your community. Just knowing what's going on in your community, how your community is preparing will be helpful. I also want you to think through the effects not only on you at your house, but how might this impact your day-to-day lifestyle. So we know in your home, you might have a disaster that impacts your home through flooding, an earthquake, an ice storm. What about in the community? What is this going to do to roads and bridges? What about your alternate routes? Do you have alternate routes planned in case your main route is no longer accessible? What happens if stores are closed or banks no longer allow, they don't have power and they don't allow debit cards? Do you have some cash on hand? Thinking about utilities, how long can you go without power, without water, without gas, phone? What are you going to do to replace them? Thinking about the groceries, what can you do to put certain amounts of food into your kits? How about medical supplies? How many days do you have on hand? And how are you going to replace those medications if a pharmacy is not open? Also thinking about pets. What do pets need? What are we going to do? I have a dog, I have a cat, so I have a pet go kit, which may seem kind of silly, but I can tell you if I have to leave my home or shelter in place, that dog and cat are coming with me. So I want to have a bag ready for them as well. We also have to think about who you're going to check in on and who's going to check in on you. So having a list of important phone numbers will be really good. I don't know about you all, I have all my phone numbers in this device, right? In my phone is where everything is, but I don't have them all memorized. So I also have like a handy dandy little notebook that has phone numbers in it that I'm able to pick up and take with me in case something happens. What if my phone is damaged in the disaster? So I want to be able to have that list of phone numbers in my go bag. The other thing is thinking about how are you going to communicate with folks? Texting often works better in a disaster than calling out. So talking to your family and friends about having a text plan, knowing my kids know that if something happens, they are to text and that they are to text as don't put graphics, don't put emojis or whatever, just put basic words in there. I am okay. You can even abbreviate it. I kind of already hit on this, but family, friends. I would also put schools, doctors, and vet numbers in there. Think about all the things that we rely upon and will not maybe have access to. Keeping lists of those will be very handy. So here's some things to think about when you're making your plan. Your family may not all be together if a disaster strikes, so it's important to think about where are you going to go, how are you going to get emergency alerts, do you have a identified location to where you can meet up, how will you let your loved ones know that you're safe, how will you reach out to others if you need to. And I love the graphic on here. I don't know if you guys ever watched The Office, but everybody stay calm. That's a big part of this. We want to make sure we are thinking through so that we can remain calm when we actually are in the midst of a disaster. We also need to know how to evacuate, and that may seem kind of scary because we think about how to shelter in place, but how are we going to leave our home if we need to? We might need to shelter in place, but what if you actually need to leave your home, you need to evacuate? Do you have an evacuation route identified? And that includes not just getting out of your home, but also driving on the street. How are you going to evacuate if roads are flooded or you're needing to get out of the area, but maybe your neighborhood is blocked off? So I talked about making a kit. Here's some of the things you can put in your kit. Kits are pretty easy to make. They can seem overwhelming when you first start because it can be a lot of different things. But what I encourage people to do is instead of having it be a very overwhelming thing, start putting one item on your grocery list every time you go to the store, add it to your cart, and then go home and put it in your kit. Then you slowly are building your kit. Some folks ask what kind of bag to use. I prefer backpacks, but other people use duffel bags. The reason I like the backpack is I like to be able to put it on my back, but I also have a lot of old backpacks in my house from when my kids were in school and wanted a new backpack every year. So you're able to, whichever kind of bag you're going to be able to use, that you want it to be accessible and easy to carry, you need to put bottled water in there, and it's 1 gallon per person per day for 3 days. Canned or dried food, and if you put canned food in there, make sure you're putting in a can opener. Some sort of battery-powered radio, a flashlight, extra batteries, first aid kit, extra prescription medication if you can do that. And then also thinking about, do you have some cash money? Do you have trash bags? Do you have other needs? Do you have infants in the home that you need baby food or formula for, diapers, clean clothes, gloves? There's all sorts of things that you can use. You can buy pre-made kits if that's your thing and would rather do that, or you can make your own based on what you know you need. Also think about kits for your car. In the wintertime when we travel, always making sure you have extra blankets, that you have flashers for the car or something to say send help, things that you might need in case your car gets stuck. And I mentioned earlier, don't forget about the pets. Here's some things you could put in a go bag for a pet, your 4-legged family members. I love these little graphics on here. I hope they're coming through on yours. A little dog turning his head and a little cat in the suitcase is super cute. But you want to put pet food and water in a bag for them, some sort of carrier or leash. I use older leashes that I had that I don't necessarily use day to day in there. A couple chew toys, any medications or shot records. If you're hesitant to put all of that in there now because maybe you use those medications, you could also have them all in one location that are easily to grab and then put right into your bag should an emergency happen. And then I also want to talk about making sure not only are we putting all this together, that we're practicing it, right? We have to think through, practice it, and not just with ourselves. Let's practice it with the people that are around us. That might be your family at home. It might be the folks that you work with. But making sure we are developing our plan, getting our kit made, and then updating and maintaining it and practicing at least every 6 months. Lastly, I want to highlight listening, where to get information. We live in a world where information is always at the ready and at the hand. and we can find it typically. But what if you don't have communications during an event? How are we going to do that? So thinking about the different apps that might be helpful to you, how the TV might be helpful, radio, but overall, just kind of using some common sense and staying calm will really go a long way. I got a quick video I'm going to try to show you. Let me see here, actually. I got to stop sharing and share again. So I can click, I think I can click the sound. Let's see. Oh, I may not be able to share it with you. I don't know if the sound is already set up. I'm going to try it and let's see how it goes. If you can hear it, Leslie, will you give me a thumbs up or holler at me?
Sure will. I don't hear it.
Okay, I got a good idea. Hang on. All right, here we go.
What do we do? You may not be able to plan ahead for a ghost encounter. Under the dining table now! But you can plan ahead for natural disasters. Sign up for local weather and emergency alerts.
Maybe it's the apocalypse.
Know your evacuation routes and decide on a safe emergency meeting location. Here?
I know. I picked Orlando.
Protecting your family is the best plan you can make. So pass the Proton Pack to the next generation and visit ready.gov/plan to get started.
All right. So that's just a good website that gives you some resources, ready.gov. We also on our DMH website share a lot of resources, as well as our DMH intranet. Now what I want to do is I want you guys to pull out your phones, or if you're at your computer and have multiple screens, I want you to go to www.menti.com, M-E-N-T-I. It should be on your screen there. And I want you to enter the code you see there, the 38927856. So I'm going to pause for just a minute so you guys can do that. And when everybody has got that screen up on there, I'd like you guys to give me some thumbs up or just put in chat that you've got those. Got it. Okay, great. All right, so what I'm going to do is I just want to do this. I don't know if you guys have used Menti before. I really like this because it gives you guys the opportunity to put it in here. It doesn't tell me who's saying it. It just tells me some of the information, and it's a nice way to get all this together. So when it comes to disasters, what do you want to learn more about? I like the nothing. Funding for preparedness, kit preparation. Yeah, so go ahead and start typing in. When you guys think about disasters, what are some things that you would like to know about? Yeah, funding. Man, me too. Helping wheelchair-bound adults prepare for disasters, kit preparedness, shelter locations, process for evacuation, okay. Kit preparation, funding, easy list of detrimental items, how to ask for help, okay. Disaster relief, how that looks, educational documents, what to actually do, okay. Tornadoes, yeah, those are scary. Okay, practical tips and tricks. Yeah, so these are good. These gives me an idea of things that you might be interested in and that I can work with Leslie to make sure we can get more information out there for you guys. So I appreciate you guys sharing all of this. This is great. Accessible shelters, I'm glad somebody put that there. Just so you guys know, every Red Cross shelter has to be accessible for access and functional needs for disabilities, every Red Cross shelter. There are things that we call pop-up shelters in the community where people just stand up their own shelter, or churches might want to stand that up that are not Red Cross. They do not have the same compliance that Red Cross has when they stand up shelters. So those are the shelters that sometimes you may run into that are not accessible. All right, thank you guys. This is good. All right, I'm going to ask you one more question, but these are still coming in, so I love it. All right, here comes the next. Excellent. All right, here comes the next question. When you guys think of your role in prevention and planning, when it comes to disasters in your job, what is your role in prevention and planning? Okay. So education, providing education to staff, to residents, not sure, okay. Keep up with, sharing resources, okay. Yeah, taking care of you and your family and then others, which is exactly why we started with personal preparedness today, for you guys to do that. Organizing, brainstorming, ensuring drills are completed, good. Helping others be safe, these are great. Oh, ensuring all medical needs can be met in case of disaster. Yeah. So I'd be curious, and you guys could put this in the chat if you want, but do you guys know what your plans are at your facilities and at your homes when it comes to disasters? Okay, gotta know. Okay, I need to ask, drill, no, yeah. Yeah, so that is definitely something we need to work on then, somewhat, okay? Ask what the plan is, I like that, yeah. Good, this is helpful, disaster plan book. If any of you have been in central office this month, you would have found some resources on a table. I don't know if you have been or not, but Leslie, you and I can talk about maybe getting some specific resources out for planning and books like that that they can take home and take to the agency. All right, awesome. I really appreciate you guys sharing this with me. Do you guys have any questions?
Chad, I'm not seeing anything, but I like the idea of working together and getting stuff out there. And we all appreciate you coming and talking to us and investing time in helping us be prepared for disasters. And am I echoing? I feel like I'm echoing.
You are not echoing on my side.
Okay, thank you.
Yeah, no, I appreciate you having me come and talk. That was a very fast presentation on preparedness. Always happy to come do more, and hopefully someday we'll all be in person again to talk through it too. So thank you guys.
Thank you so much, Becky. You have a great day, and we'll keep in touch. Yes.
Okay.
Bye-bye.
All right. Bye-bye.
All right. It is now time for our lunch break. And if I remember correctly, I don't believe, try not to log off for lunch. If you have to, you have to. I understand, but you can stay logged in and just mute yourself. And we'll just start right back up at 1 p.m. Okay. So everyone take time, get away from your computer if you can, or your phone, and try to get some fresh air or some you can go ahead and resume our learning. I hope everybody had a great lunch. I hope you're able to practice a little self-care and maybe get outside a little bit or get something to eat or drink. And our next speaker, I'm not sure if she's logged in yet, so sometimes WebEx can be a little tricky. But I would be honored to hang on, let's wait. I'll introduce her whenever she's able to log on. But our next topic is related to hospice services and also palliative care and differences in the two. And because we know that's a very important part of end of life planning and just me working with people across the state, it does look like people are utilizing hospice services, and anticipating, that kind of need for the people we support. And hello, Monica. Welcome. I'm going to go ahead, or do you want to? Okay, I'll go ahead and introduce you and turn it over to you if you're okay with that. Great. It's great to see you. All right. Our next speaker is Monica Corba. She is a registered nurse and serves with Compasses Hospice. She received her nursing degree from Columbia College in Columbia, Missouri, and also has her bachelor's degree in psychology and sociology from the University of Missouri, Columbia. She is going to talk with us today about hospice services and palliative care. I'm discussing the benefits as well as the differences, and I will now turn it over to Monica. And if you give me just a second, if you need to share your screen, I can pass you the presenter square or whatever you want to call it. Okay, I'll go ahead and hang on just a second. I need to slide down a little here. Make presenter. Okay.
You are now the
All right.
presenter. Hi, guys. Let's see. Google Chrome. Yes. Share. Okay. And then I think I can present. Okay. Oh my goodness. Look how fancy we are. Hi, guys. Thanks for having me back this year. I just absolutely love talking about the services that we can provide. I know that you guys do really great things in the community. So I want to thank you for everything that you guys do. I'm just here to kind of tell you about some of the extra services we can provide for some of your folks. So I titled, I go back. Oh boy. Okay. Nope. I got it. All right. So I titled this Choices in End of Life Care, because a lot of times, sometimes people forget that there are choices in end of life care. One of the reasons I went into hospice care was I had been working in the ICU for a really long time. And it felt like that conversation was just completely missing from any of the care conversations that we're having. But there are choices, and that we don't necessarily have to continue to be aggressive with treatment, that we can shift the focus to comfort. So that's why I entitled this Choices in End-of-Life Care. So palliative care and end-of-life care is used to reference the care received in the final 6 to 12 months of life. While hospice extensively uses a palliative care approach, palliative care is used in a wider context outside of hospice and is often initiated earlier. So palliative care is the big umbrella, and then hospice is underneath that umbrella. So hospice is palliative care, but palliative care is not hospice. Catch that? So hospice is a type of palliative care. Well, what do we provide with our palliative care services? Well, Compasses provides a community-based palliative care service. Some of the things that we might provide for your people are discussion of treatment goals, and sometimes we call that goals of care, discussions of advanced care planning, discussions on symptom management associated with withdrawal or curative restorative treatment, and then any symptoms managed associated with a serious illness. And I like to say, when we say symptom management, I make sure that we point out that we're not just talking about pain, we're also talking about dyspnea, nausea, anxiety, opioid-induced constipation. Really, palliative care is appropriate for anybody with a chronic illness that has symptom management problems. These are people that are calling the doctor's offices frequently or having to go into the doctor's offices, go into the ER, etc. They just need a little bit more care than your typical person. Go back. So some examples of that might be, are somebody that might be on chemotherapy, that's having problems with like nausea while they're going through treatment, or somebody who's on dialysis. They can continue getting those types of services, but palliative care is an additional service that they can provide. And really, it's treated as a consultative service. We focus on relieving stress and symptoms associated with a serious illness. Our goal is to improve the quality of life for both the patient and family. And our consult can be provided along with curative care. We offer an extra layer of support. So what does that look like? Well, in our program, like I said, it's a community-based program. We have a nurse practitioner that comes out and visits people wherever they reside. She will come into their home environment and do a head to toe assessment, look at all the medications, and kind of be like the liaison between all the different doctors. You know, a lot of times people get these cardiologists and neurologists and all these different doctors who focus on each specific system, but you never get somebody who just looks at the whole picture. And that's why I think the palliative care program can be so great for somebody who does have complicated illnesses and chronic illness that maybe has some trouble with symptom management. Um, let's see here. I don't know if you can see that part, but it's in my way. All right. So here is a slide that talks about the differences. So palliative care, like I said, is a serious illness. You can be seeking life prolonging curative treatment. There's not really an eligibility criteria. If you think someone might be eligible, they probably are. And it is a Medicare Part B billed service. So hospice, you have to have a terminal illness, which we'll talk about here in a bit. You can't be seeking a curative treatment. You must meet end-stage disease criteria. So for each diagnosis that they would be using as considered their terminal illness, there's certain requirements for each disease that they have to meet. And then it is a Medicare Part A benefit. All right, let's see. Oh, okay, there we go. All right, so what is hospice? Hospice care is a set of services provided to patients and families facing a terminal illness. The focus is on care, not cure. Hospice embraces the quality of life rather than the length of life. We provide an alternative to routine home care and repeated hospitalizations. And really, it's about living life to the fullest in a secure and familiar surroundings with those who matter most. I know a lot of times when folks hear hospice, or sometimes I like to call it the H word, they get really upset because, you know, in our culture, you know, hospice a lot of times is automatically seen as giving up or forgotten about or less care. And all of that can't be less true. It's exactly the opposite. It is a team-oriented approach to providing specialized care for people facing a life-limited injury or illness. It includes expert medical care, pain management, and emotional support for patients and their families. But more simply, it's about living one's life to the fullest with dignity, regardless of how much time remains. It's really about just shifting that focus and making it about comfort. At the center of hospice care is the belief that all people have the right to die pain-free and with dignity, and that their families receive the necessary support to assist them. And again, I kind of go back to like my ICU days when I was watching people really suffer towards the end of their lives and continuing to receive really aggressive treatments, sometimes wound care, that they would have to pre-medicate before doing aggressive wound care. Really when we all kind of knew what the end outcome was going to be. And that was really upsetting as a nurse to participate in. So this, like I said, really resonates with me. Let's see. So something that, like we talked about before, people hear the H word and they think, oh, we're going to give up or we're on our deathbed, we're going to die tomorrow. That's absolutely, well, it can be true, but it also doesn't have to be true. We recognize dying as a normal process that involves a patient, family, and hospice. We focus on comfort, not cure, but we don't hasten nor hinder. I always tell people we are not changing anybody's timeline. We are just walking alongside you in your journey and keeping you comfortable while you're here with us. That's not our job to make you last longer or go quicker, which sometimes is upsetting for families and patients to hear because maybe sometimes they have those preconceived notions and they think that those things are going to happen. And that's just not what we're here to do. All people, here's some myths and facts. All people who enroll in hospice will die soon after they are admitted. So this says that 700 and whatever, so a bunch of people were discharged alive from hospice in 2011. And at that time, the average length of stay was 69 days. That's like 2.5 months. Ultimately, what this is saying is there's not always one outcome when somebody's admitted to hospice. There's a couple things that can happen. Somebody can come on hospice and they can pass. That is the most common outcome. However, people can come on hospice, and sometimes when they stop taking some of those aggressive medications or treatments, they actually end up feeling better and sometimes improve so much that we're unable to recertify them, and then they're no longer eligible for hospice. And then we call graduate those people. So sometimes folks can graduate from hospice because they get better, Or maybe someone changes their mind. Maybe they decide, you know what, there's a new treatment available and I want to give it a shot. Great, sign this paper, go do your thing. If you change your mind, we'll be here waiting for you. As long as you're still eligible, we will put you back on hospice whenever you're ready. So it doesn't always mean that you are going to die the next day if you come on hospice. Okay. Sometimes people die sooner than other patients who don't choose hospice. Again, this is not true, and studies show that the mean survival was 29 days longer than those for non-hospice patients. So they lived an average of 1 month longer than similar patients who do not choose hospice. And again, I think that a lot of that is because we're focusing on those things that are most important, which is comfort, spirituality, and family time. So I think that's an interesting thing. Okay, so what do we provide? What is hospice? What does it look like? Well, one of the best things I think that we have to offer is our 24-hour on-call staff availability. That is quite a bit different than the palliative care. Sometimes palliative care thinks it's hospice light, and in some ways it is. With palliative care, you just get your visit, once a month from that nurse practitioner. And if you have an emergency, sure, you can call and try to schedule another visit, but we probably won't get out for a couple of weeks. It is not an emergency service. It is a consultative service, just like going to the doctor's office or a clinic would be. But with hospice, we are available anytime, 24 hours, 7 days a week. The people that we provide are nurses. We have RNs, LPNs, we have home health aides, we have social workers, who provide counseling as well as spiritual support. We have chaplains. A lot of times I like to stop here and say, chaplain support isn't necessarily a religious support. It's more of a spiritual support than it is a religious support. But if religious support is what you need, then certainly they can kind of pivot and provide whatever it is that you're looking for. We also provide volunteers. This is really great for folks who maybe don't have a lot of family or friends, or maybe they live out of state and they're not able to come and visit, and they just want someone to chit chat with and to provide a little companionship. So what we try to do is, if somebody might be interested in a volunteer, we ask them questions about what are your interests, what do you like to do? Do you like Westerns? Do you like country music? Do you like to crochet, fish, etc.? And then we try to match them up with the volunteers. And if you have somebody that wants to volunteer, you just let us know. And then, we're at the mercy of the volunteer schedule. So we can't always guarantee that there's going to be somebody available, but the sooner we know, the more we have to work with it, reaching out to people and getting those people set up. We also have specially trained Angel Watch volunteers, which are people that will come and sit at the person's bedside so that they don't pass alone. And again, that's good for people who maybe don't have family, or they live far away, or maybe the family and caregivers are just getting exhausted and they need a break, and they don't want to feel like if they fall asleep, they're gonna pass by themselves. So a lot of opportunities there. We provide equipment, durable medical equipment, and most common, a lot of times we use hospital beds, and they're handy because a lot of times these folks have trouble sleeping with their head down. And so, maybe they're better in the recliner, and we say, great, if that's where you want to sleep, good for you. But if the recliner's not comfortable and they don't like the bed, then a hospital bed can be super handy. Sometimes you just kind of have to kind of explain it that way, because sometimes people get a little bit weird about having a hospital bed. They think that means that they're done, and etc. But it can be super handy. We also provide, let's see, equipment, oxygen, suction, wheelchair, walker, all kinds of stuff. Basically what I tell people at this point when I'm going through what we provide is, if you need anything for the care of your loved one or the person that you're caring for, call us first before you go and buy anything, because most likely if you need it for the care of your loved one, we are going to be able to provide that for you. We also provide medical supplies related to terminal diagnosis, and most often I call this incontinence supplies, because that just covers all the things that we provide, like briefs, wipes, powders, lotions, all that kind of good stuff. We provide end-of-life bereavement counseling for a minimum of 13 months after the person's passing, and that can be utilized as often or as little as that person wants. Usually we'll get the primary caregiver or loved one as the contact, and then we contact them and kind of set that up for whatever they want it to look like. Now, I understand that you guys can have long-standing relationships with your patients. So I just want to use this time to let you know that if you guys are having any difficulties with some losses with your caseload, please don't hesitate to reach out to our office and ask for some bereavement resources, because we recognize you guys as caregivers, and I know that it's difficult when you get to know people and they pass. So please reach out if you need that. We provide pharmacy needs related to terminal diagnosis. And what that means is if their terminal diagnosis is congestive heart failure, then most likely we're going to cover their blood pressure medications and Lasix and anything related to that, plus anything for their comfort. So I don't really want to make this too muddy, but if we don't cover a medication that they're currently taking because it's not related to terminal illness, they can still take that medicine. It's just not something that we're going to cover. It's going to go through their insurance like normal, so it's not going to cost any more money. It's just that hospice is not paying for that particular medication. And a lot of times I use the example of a thyroid medicine because I feel like a lot of people are on thyroid medicine and it's not usually a terminal illness. So I will say, if you are on a thyroid medicine, you can keep taking it. We're just not going to pay for that prescription. It'll just go through your insurance like normal. We cover PT, OT, and speech when needed to improve quality of life. This can also be a little muddy and tricky. Every hospice treats this differently. It's not used very frequently. However, I think that PT can be very appropriate if you have somebody that has a very specific goal. If they're wanting to, I'm having trouble repositioning myself in bed, or I'm having trouble sitting up on the side of the bed, or I just really want to be able to brush my teeth. The thing that the person needs to have is a very specific goal in order to receive this therapy, because it's a very limited amount of therapy. It's not going to be like a full rehab. What it usually ends up looking like is you can get an evaluation, which is one visit, and then the PT will come back a second time to do the program. And at that point, what we try to do is get somebody from our team to accompany them during that visit so we can see what program they're setting up for them. And then on the third visit, our team will kind of, oh, good question. Somebody said, wouldn't they be reevaluated for palliative? I'm assuming that question was referring to people who would come off hospice because they were no longer eligible. And yes, that is a very good question. And yes, if someone graduates from hospice because they're no longer eligible, they 100% can go on palliative care services. The only time that sometimes that doesn't work is if for some reason their insurance doesn't cover our particular palliative care, it's out of network. Oh, PTOT, because of want or need of PTOT. Let me think about that for a second. Well, palliative care is separate than hospice. So if somebody is wanting PT or OT and they're on hospice, like I said, we can do that limited amount of therapy. But if they're wanting something more, then yes, we could have them discharged from hospice. We could put them on palliative, and then yes, they can get all the PT and OT they want because it is a Medicare B benefit where PT and OT are Medicare A if they do a full rehab. Does that answer the question? Yes, yes. The PT and OT that is happening during hospice is limited. And like I said, the most I've actually seen visits be done is like 3. And then what we try to do is have our team come in and learn whatever program the PT is teaching so that when we come and visit, we can do those like active or passive range of motion exercises that the PT has suggested. So thank you for asking that. But that did bring me back to the palliative care. If somebody becomes not eligible for hospice because they got better, then one of the first things we'll do is say, would you be interested in our palliative care program? Sometimes they don't want to because there is a copay, just like there would be at a clinic visit, and maybe that's a financial barrier there, or maybe the insurance doesn't cover it, or maybe they just don't want to do it. And in that event that they don't want to do palliative care, the next thing we would ask them is it okay if we keep you in our transitions program? And what the transition program is that we basically keep them in our kind of like our pot to check in on every couple months, just so they see how things are going, make sure that they haven't started declining again, because if they have started showing signs of decline, then we might come back out and reevaluate and get them back on hospice. So thanks for bringing that up because it brought me back to the palliative. All right. Respite care when families need a break from caregiving. I think most of your people are already getting 24-hour care provided for them, but in the event that somebody is having to depend on their family members to take care of them, if in the event that their family members just get tired or they get sick or they need to leave the state to go to a funeral, they can be put into a 24-hour facility that we can contract with one of the facilities in whatever area they live in, and they can stay for 5 days, and that would be covered by hospice. That can be confusing. If anybody has any questions, please chat me. And then hospital care when needed for symptom management. This is another really good point. A lot of times people feel like when you go on hospice, you have to give up your medicines. Not true. You keep taking your medicines. And if it's not something we cover, you can keep taking them. You just pay for them like you usually do. But also, well, what happens if I need to go to the hospital? Well, obviously our goal is that you don't have to go to the hospital. However, if something were to happen and you were to fall and you get a big gash in your forehead and you need stitches, we're not going to just let you bleed out and have this big gashed forehead happening. Or if somebody were to fall and break a hip, that's obviously very uncomfortable. And if our goal is for your comfort, then we're not going to let you lay there in discomfort. We would take you to the hospital, get your hip fixed, or do whatever we need to do. You would stay there while symptoms needed to be managed, and then you'd come back home when it was appropriate. The most common reason I would say people go into a hospital while on hospice is probably falls. But also sometimes just the symptoms are so severe that it's just we're unable to get them to a reasonable, the symptoms are not reasonable for the caregiver or the patient. So sometimes we need to get them back in to do IV therapy or whatever else they might be able to offer us in the hospital. So those are things that can happen if you're on hospice. Again, you can stop hospice at any time. You always have the right to stop for any reason. You'll get the type of Medicare coverage you had before you chose. So it's just going to go back to what you were doing before you came onto hospice. And if you're eligible, you can go back on hospice anytime. So what is the reimbursement? We kind of briefly talked about this, but it is a Medicare and Medicaid benefit. Here in Missouri, it is a Medicaid benefit. If you have private insurance, that's where sometimes it can get hairy. I've had situations where we're just not in network, that our particular company is not in network. But if that's the case, what we would do is then help you find someone that is in network. We do provide services for people who are not funded, meaning if they're indigent. We would never want to deny someone services because of a financial reason. So we are going to figure that out. So don't ever hesitate to tell someone about our services, even if you feel like maybe they don't have the resources, because we have lots of things we can do to make that happen. Veterans Administration. Yes, we contract with them, and they can be on service with us with the veterans benefits. If they do want to go back to the VA hospital, they do have to come off our services because the VA has their own hospice stuff, but that's a whole other conversation. And then also another thing, because I don't know if you guys do pediatrics or not, but we can do concurrent care with kids on Medicaid and hospice. And that means that they can pretty much continue to get the same care they were getting. And it's just like hospice is an additional resource. Like they don't have to give up any aggressive care because hospice is a wonderful resource for those kiddos that need it. Let's see, potential medical diagnoses. A lot of these I think you're familiar with, but we'll just kind of review them. This is a disease in which a doctor would certify life expectancy of 6 months or less if the disease runs its normal course. So cancer is almost always going to be a diagnosis that we're going to approve for. Pulmonary disease, whether that's COPD, pulmonary fibrosis, heart disease, maybe somebody's had so many stents and cabbages that they just don't have anything else they could possibly fix. Or congestive heart failure is a really frequent one. Alzheimer's disease and related disorders, stroke or coma, liver disease, renal disease, neurological disease, and HIV/AIDS. Signs that a patient may be eligible for hospice. So, when we talk about someone needing to be at 6 months or less in order to be eligible for hospice, that's super gray because everybody is going to look a little bit different, especially depending on their age and their previous baseline, what their diagnosis is. But these are some things to look at when you're questioning whether or not you think someone might be eligible. Frequent hospitalizations often related to recurrent infections and falls, progressive weight loss, usually 10% in 6 months or 5 months and 3 months, increasing sleeping, spending more hours asleep than awake, deteriorating mental abilities, increased confusion, withdrawal, or decreasing alertness, decreasing food or drink intake, increased assistance with activity of daily living, such as dressing, bathing, toileting, walking, and weakness and fatigue that includes shortness of breath and frequent falls. I feel like the two huge red flags are when someone starts sleeping more and eating less, there's something going on there, and that doesn't necessarily mean they're dying, but something's happening. So like, do we need to get a UA, make sure it's not just a UTI? Okay, great. But then once we rule that out, okay, we need to look at something else and see what's going on here. Those are things that you're going to see. Okay. So how can we help? We provide a team that will work with the caregivers and the doctor to provide comfort and dignity to ensure enhanced quality life. And this is also really nice because a lot of times with people, us being kind of the in-between, like having to call the doctor for like dosage changes and things like that can be super helpful because we know what to ask for. And, that's basically it. We know what to ask for. We know how to get what we need. We offer the 24/7 availability. There's never an out-of-pocket expense or bill for hospice care to a patient or caregiver. Now, I need to change that because if they do have private insurance, there can be copays or what is it? Oh my gosh, brain fart. When you have to pay a certain amount of money, your deductible. Thank you. I did that myself, deductible. All right. So there can be a deductible, but ultimately, if that's not like a financially feasible thing for somebody, we can work around that. That's not at the end of the world. Compassus is here when you need us and we'll coordinate care within 2 hours. Now, I would say in the last year or so, I'm being liberal here, it's become more difficult to be as prompt with our hospice admissions because of staffing. However, it is still our goal that when somebody calls and it is an urgent referral, that we get out there to evaluate the person and admit them if eligible. And if for some reason we're not able to, we're going to make sure that we can find someone who can. So that is still true, that we are still advocating for people, but we can't always do it that same day, which is sad. But that's just the world that we're in right now because of the lack of bodies. But anyway, okay. So we have patient-oriented principles. Hospice provides comfort rather than curative. We focus on managing the symptoms. We assess the needs of the patient and monitor changes. I would like to add there, we assess the needs of the patient, but the family as well. We understand that family and caregivers are going through a lot as well, and they can need just as much as the patient does. We respect the wishes and the rights of the patient. We allow the patient to have autonomy so they can feel like they're in control. A lot of these folks have been, ill for a long time and have really lost a lot of the autonomy and that feeling of control. And hospice kind of puts them back in the driver's seat and lets them be the captain of their own ship and say whatever it is that they want, they're going to get. Especially if there's somebody that's maybe been on a specialized diet, like a mechanical soft. It's always exciting for people to be like, you mean I can eat whatever I want? Well, yes, but you have to understand that the risk is that you could choke and that could be a problem. And many times if they're cognitively able to, they're like, yeah, don't care, I want to eat. Each patient's care is individualized. We provide holistic and spiritual care. Resources are available to help with planning, and hospice meets the patient and family wherever. That meaning that it's not just in a hospital or a facility, but we can go to their home. I've been to some interesting places with my vehicle. I'm sure you guys have too. But that again is for another day. All right, let's see. Oh, this is my favorite part. We are talking about creating advanced healthcare directives. Hopefully your folks already have this in place, and that's great if they do. If they don't, this needs to be done. But really, this isn't for them. This is for you guys. Raise your hand if you have an advanced healthcare directive. Raise your hand. Hi. I can't see anybody, but I'm assuming that you're all raising your hands because you're all educated professionals. But in the event that you don't have an advanced care directive, it is never too young to get this taken care of. Oh, yay. Thank you. Someone said yes. Yay. Round of applause. It's never too early to get this done. You need to identify a surrogate decision maker. If you are unable to make decisions for yourself, you need to have somebody identified who's going to follow the wishes that you have. what's really important is that you make sure that that person knows what your wishes are, so they're not confused when they get to your advanced directive. They're like, wait, what? I didn't know she didn't want any of this. So you want to have a durable power of attorney if possible, while still healthy and speaking for yourself. Ask questions. Just because a treatment is available doesn't mean you have to use it. This is just so important. I think it's really easy for us to be in the caregiver spot and think, well, that's never going to happen to me. I don't need to do that. I'm only 44. We all know better than that. Things happen every day. The next day is never promised to us. And I think if I've learned anything in this line of work is that I want control over what happens to me, and I don't want someone else having to decide and then feeling guilty about the decision that they made. I want to be like, hey, listen, I already did all that hard work for you. Decision's already made. You just have to read off this paper and tell the doctor. So I'm sure that you guys have experienced this, but just as a reminder, make sure it's somebody that you trust will follow your wishes, because in the event that you're unable to make your own decisions, if the person you have chosen changes their mind and doesn't want to follow your wishes, the medical team has to follow whatever that person says, because that's the person you designated. So that can be tricky. So very, very important. So thank you for all of you that already have one. But if you don't, here is your reminder. You can literally just Google Advanced Directive Missouri, and you can print them off. And then you just need a notary. Just take it to your local bank and they will sign it for you. And then also, it doesn't do any good to do these things if we do not share them with our primary care physicians, our hospitals in our area that we might visit, and then any family members that need to have a hold of them. So get it done and then share with the appropriate people. Okay, in conclusion, 90% of people say they want to die at home. 80% of people with chronic diseases say they do not want to die in a hospital, especially not in an ICU unit. Less than 25% of people die at home. So it says approximately 75 to 80% of Americans die in facilities, hospitals, and nursing homes. I consider nursing homes a home because that is where they live. So I would like to see a more accurate percentage for that, but ultimately less than 25% are dying at home, maybe a little bit more if you count the nursing homes, but not enough, especially when 90% of them want to be at home. So anyway, that is the, let's see, I don't think I have anything else. Oh, one thing I did want to add, since I'm here, is that we are, Columbia is getting a nonprofit hospice house. Has anybody heard about this? It's called Healing Hearts and Hands of Columbia. It's based off the Omega Care model. Because of zoning restrictions in Columbia, they can only have 2 patients at a time. So currently there's only going to be 2 beds. I think it's slated to open in March. And that home is for people who maybe financially can't afford to go to an assisted living or a skilled nursing facility, and they're at the end of life, and they have nobody to care for them. Or maybe there's somebody that, it's a younger person who doesn't want to die in their home because they have teenagers and young children and they don't want the home to be associated with that. That might be another reason somebody would want to go to the hospice house. But anyways, it is a nonprofit. I think that there's a similar setup in Joplin if you're curious, you want to look into it. But I think that might be the first home in Missouri is in Joplin, and then the second one will be in Columbia. So anyways, I just wanted to mention that because I think it's important that people know that that's an option. Obviously, there's going to be a long waiting list, but hopefully we can get some of those zoning things figured out and get some more beds in there. So what questions do we have?
I think we have about maybe 5 minutes for questions, if that sounds okay. So if anyone has any questions they want to drop in chat for Monica to answer. And Monica, that was great. I learned something every time I hear you. That was really informational.
What was the name of the hospice house in Columbia? Well, let me Google this just to make sure I'm telling you right. Oh, and they're having an event at Stevens Lake Park on October 15th. It's an Illuminary event. And so, yes, thank you. Caring Hearts and Hands. Oh, wait, hang on. Let me see. Hang on. One thing at a time. I think it's Caring Hearts and Hands. Yeah, Caring Heart. Okay, yeah, but their actual website, I guess somebody else had their website. So the website is Caring Heart, just one, and hands.org. But the name is Caring Hearts and Hands of Columbia. It's a social model home for end of life care designed to alleviate the burden of families facing physical, emotional, and financially when taking care of dying people. And the event is on October 15th at Stevens Lake Park. They will have, you can buy an illuminary to set up in honor of someone that you've lost. Oh, I missed that question. How do I get back to that question? I'm going to stop sharing. Let me get back to the chat. Okay. Oh, yes. It's Doreen and yes, let me see. Okay, hang on. Let me go back. Can you make sure families know that when you loved ones die, there's someone who could just have them sit as they are dying? I ran out of energy to sit to the end. Yeah. So our goal is to have a volunteer that can sit with that person, but we can't guarantee that there'll be somebody who sits with somebody towards the end, because it really depends on our volunteers. Because as far as our staffing, we're just not staffed to be able to sit with a patient while they're passing, which is hard. And I get it, because it is exhausting. It is literally the hardest thing you'll ever do, is sit at a loved one's bedside while they're dying. So what if you think that that might be something that your person will need, my recommendation is to ask for it as soon as possible so that we have time to look for those people and schedule those volunteers in increments. So there's always somebody there. And then Tony says, I know Doreen Rardon from my days with the hospital. Same. And then also Jackie Reed and Doreen Rardon, they're the ones that started that. With our individuals, what is the process to access palliative care? Good question. So basically we just need a like a referral from their doctor. If you yeah, would that be, is that a yes, I would just ask for a referral from the primary care doctor. Oh, okay. Someone wanted me to share that there are griefshare.org. There are grief share groups available in many areas. Yes. And I think that they have those. That's a good thought. I just had that for somebody. I would just thought back in my head. I think that those also have different groups. So like maybe if it's a younger person who lost a husband, so maybe sometimes different ages, you don't want to get into a group if it's a younger person with some, elderly people. So griefshare.org is a grief group. Oh, yes, there is a 20-bed inpatient facility in Rogers, Arkansas called Circle of Life. It is a really amazing facility. Oh, love that. I wonder, is it, griefshare.org. There we go. Oh, such a good point. Remember your own skills and assets we can share. I've sat bedside with my guitar and sang to individuals several times. Yes, don't underestimate your skills to provide some of that care. Yeah, music. I always say when I'm telling people or caregivers how, like, because they're just so uncomfortable, they don't know what to do. The first thing is to remind somebody that no, even if they're not communicating with you, they can always hear you. So just talking can be a form of therapy for the caregiver and for the patient. Talking about, good times, memories, all those things can be super helpful. But also music is huge. Lighting, smells, if you can get some essential oils in there. Essentially, you're setting the scene. Set the scene, and you want it to be as comfortable as possible for everybody in the room. Something I want to share, some really exciting news. I don't know where he is. Probably eating something because not supposed to. But for the last couple of years, I've been working on getting a service dog to be my coworker, so that when I travel and talk with facilities like I am with you guys today about what hospice is and how we provide care, or when I'm meeting with families to explain what it is and answer any questions they might have when they're considering using our services, those conversations can be really hard. And I really saw a need for animal therapy to help bridge some of those conversations when they're really difficult. So I just had a fully trained facility dog placed with me that earlier this month. His name is Mars. Again, I don't know where he's at. Otherwise I would like move. Hey, Mars, come. He's really good. He listens. Just kidding. Mars, come. Here he comes. Okay. He's sleeping. Poor thing. Yeah, come here. Here, let me see if I can get it. Mars, are you a good boy? Yes, you come and help all the people. Look at all my laundry on my table. This guy is so good. He's not as great when his cape's not on, but when his cape comes on and he's got his working leash on, this guy is like all work. He just lays down and provides comfort and compassion to whoever needs it. And it's really interesting because a lot of times he knows when people need it. So he'll just kind of like flop his body down on their legs. And it's just so awesome. So anyway,
Oh,
so that, yeah, I know,
Monica,
right?
thank you so much. That's I think that's brilliant. What a lovely dog. And just there is something about petting. Yeah, you're like, oh yes, yes. Anyway, no, but just petting an animal to break the ice. It does promote relaxation. I know there's been studies done for what if you're lonely, get a pet, and it really enhances your life, right? That's so smart. And thank you for letting us see him. That was so cool. And I hate to do this, but I'm gonna probably just kind of wrap it up. And if we well, any questions that have been put in the chat, we're going to do like a Q&A page. So I may reach out to you to make sure I'm putting a proper answer on. And then also, if any more come to us, I will reach out to you and get those questions answered. But you're always a delight. You have such a passion for helping people. And just thank you for sharing your expertise and your passion for this subject. It's something that, we all really need to think about and utilize. And then, palliative services, I never really knew a lot about them. And it's neat to know that they can be used well for people with chronic conditions, and it isn't just a end of life type of thing, so yeah, thank you so much.
I do want to say one more thing. If you do have people you think that might be eligible for palliative or hospice, don't hesitate to reach out to us because we can a lot of times do the legwork and do that back end work. Like if you think that somebody might be eligible, what we can do is maybe call the doctor, ask for permission to get an evaluation, and then we can take it from there. So you can get the order from the doctor, but if it's hard to get a hold of him or he doesn't call back and it's urgent, don't hesitate to call us and we can take it from there. So again, thank you so much. I love talking and sharing, and it's just so important for our community to understand what resources are available. So have a good day.
Hey, thank you. You too. We appreciate you. Thank you. Bye-bye. Okay. And if I could take if Kat, if you're able to give me, I'm the presenter. You read my mind. All righty. I'm going to share my screen. We have a treat right now, our own Division of Developmental Disabilities, two of our own that will be our next presenters, and they're tagging on to the kind of the hospice end of life presentation, that aspect of it. We saw a need for this, and they have prepared a presentation for you about our Department of Mental Health's Do Not Resuscitate orders. So our presenters are our own Ashley Mort, who is a registered nurse, and she works as a quality programs nurse for the Joplin Regional Satellite Office for our division. And then we have Michelle Cooper, who is a registered nurse, and she also works as a quality programs nurse for the Springfield Regional Office. And I really want to thank these ladies for preparing this presentation. And I will turn it over to whomever is.
If you want to pass me the ball, it's Ashley.
Sure thing. All right, I think you might have it now.
All right, let me share my screen with y'all. Okay, so Michelle and I will be talking to you all about the DNR process today. We're going to focus on notifications, the differences, the different types of DNRs that we have available for individuals in DMH services, as well as what the responsibility is for you all as provider agencies. So the Division of Developmental Disabilities supports the rights of individuals who receive services from the Division of DD to obtain, refuse, or discontinue life-sustaining treatment. As Monica mentioned, competent adult individuals have the right to execute advance directives.
And so it's important to recognize the time when quality of life is more important than the quantity of life, which we talked about a while ago. DMH respects those rights of the individuals to refuse the life-sustaining treatments and has created a directive providing specific instructions for contracted providers to support the individuals they serve in making these decisions. We're going to be discussing this process and defining the differences between the types of physician orders that you might receive for these individuals. So the first one we have is the alternative to CPR. So if the planning team and the physician have determined that the individual's current condition is such that performing CPR would cause more harm than good, you can go around to get an alternative to CPR. Excuse me. So examples of types of conditions that would be justified for an alternative CPR include like osteoporosis, kyphosis. Maybe they have CP and they have anatomy abnormalities that would cause more harm than good. Just note that the justification of none or intellectual disabilities is not a reason to have an alternative to CPR. Just because somebody is intellectually disabled does not mean that they qualify that performing CPR would cause more harm than good for this person. An alternative CPR is also not a workaround for a DNR. So let's say a family member is a guardian for your client, excuse me, and they're really pushing for a DNR, but the client really doesn't qualify for a DNR. This is not the way to go about it. You have to have a justifiable reason for an alternative to CPR. It truly has to cause more harm than good to perform traditional CPR on an individual to have this particular order. So the planning team must keep in mind that the mission of DMH DD is to habilitate, treat, and or rehabilitate the individuals it serves. So the alternative to CPR or is merely a way to provide emergency interventions without causing further harm to these individuals. Go ahead, Ashley.
And so as the provider, the direct support professionals, in the case of alternative to CPR, they will be responsible for reading and understanding the prescribed intervention of the order. There are a number of different alternative interventions that could be prescribed, things like fingertip compressions, doing rescue breathing only, positional compressions, so on and so forth. So the direct support professionals should learn, understand, and be able to provide those in the event that they would need to complete this. As the oversight RN, you should provide education or delegation for those interventions to those direct support professionals. You can also educate them on signs and symptoms to monitor for, if there are any recovery treatments. Please also help the direct support professionals understand when there is an emergency and when to contact 911 to make sure that everyone is receiving care in the way that they are supposed to.
I'm missing this particular slide. I'm so sorry. So the in-hospital DNR is just that. It is a DNR that is ordered by a physician when the client is an inpatient. They are admitted to the hospital. I'm just sorry. Lost my train of thought. I apologize. So it's not uncommon that our individuals will decline quickly, and sometimes they're in the hospital when this happens. At that time is when the physician, the medical team may determine that it's appropriate to have a DNR in the hospital so that they would not seek life-sustaining interventions in the event of an emergency. So this would be discussed with the individual's legal guardian or legal representative. So if they have a PA, it would be discussed with them. If they have a family guardian, those people would get together with the medical team. The medical team would then educate them on the current condition, what they feel the progress is going to be, and that that all events or all medical needs have been met and there's just no getting better. It's at that time that they would make the decision for the in-hospital DNR. Once that decision is made and determined by the medical team and the representative, the attending physician will write that order in the hospital chart. The hospital DNR is only effective while the individual is admitted to the hospital and becomes a permanent part of that individual's hospital record. The written DNR indicates that the medical staff will not perform any life-sustaining efforts in the event of an emergency or when vital signs stop. This order is not effective in the community. This is only for hospital admissions. This order will not prevent EMS from providing life-saving efforts in the event of emergency in the community. If the person is out in the community, they're having an emergency situation and EMS is called, they will provide CPR and life-sustaining efforts until they reach the hospital. Once they reach the hospital, if it's known that they have a hospital DNR, it needs to be communicated to the medical staff there, and then they can go about just making those decisions in the hospital, but only in the hospital. At any time during the hospital stay, this particular order can be revoked either by the medical team or the legal representative.
As Michelle said, this only applies when the individual is in the hospital. So the direct support professionals and you as the oversight RNs really have no responsibility in regards to this type of DNR. You'll provide CPR in the home if that is needed. You will provide any other life-saving measures that you can. And as RNs, you will continue to provide that education and delegation to the direct support staff as it's needed.
So then the next thing we have is our individuals, as they gain in age, obviously their health status begins to decline, whether it's age, chronic illness, frequent medical treatments, physician visits, what have you. This can be very tiring for an individual, and it would be appropriate then maybe to have an out-of-hospital DNR. This would be a discussion you would have with the client's primary physician. This is also known as the purple form in many areas. This is a DNR order that is presented to emergency services in the event of an emergency situation. So let's say your client collapses and they have, they've stopped breathing and you're providing rescue breathing for this person. When the EMS arrives, this is the form you would hand to them. And then EMS would then be able to determine whether or not to continue the CPR or to stop. This order provides instructions for those emergency personnel, like I just said, to provide the individual with treatments that they've requested in an emergency event. This form can be obtained online or at your local hospital. I believe there are also forms in most primary care settings. This does have to be signed by the individual's legal representative and the attending physician, and it should be reassessed and reassessed on an annual basis. Your staff are responsible to provide emergency CPR until emergency services arrive.
Yes. Again, this one only applies to those emergency services personnel. So the direct support staff will provide CPR up until EMS arrives. And then it is super important to make sure that this form that you filled out or that they've filled out, the guardian or the individual and the physician, make sure that it is kept in a safe location where all the team members working with the individual can access it in the event of the emergency. So that way, once EMS arrives, the direct support staff can just hand that form to them and they will know what to do. And again, as the Oversight RN, continue to provide that education to the DSPs so that they understand what this process is. Now, in our DMH world, our number one goal is to ensure the health and safety of the individuals we serve. By utilizing your nursing judgment and knowledge, you devise, improvise, educate, and implement treatment plans within the confines of physician orders and provider policies to ensure all safety and healthcare needs are met on a person-specific level. However, there does come a time when all of your efforts have reached their limits, and decisions need to be made regarding end-of-life choices. You, as RNs that have worked with these individuals very closely, are one of many advocates for the individual, and with your increased understanding of healthcare needs, you can help guide the planning team in making those difficult decisions. One of those difficult times is assessing when it may be appropriate to switch to things like comfort cares, ceasing any heroic life-sustaining interventions within the home and community settings, and working with them to obtain our DMH non-hospital DNRs. Either with or without hospice services in place. As you can see here, there are two ways to accomplish a DMH non-hospital DNR, which we will discuss in detail in these following slides.
So if the planning team, the physician, and the legal representative, guardian, PA, what have you, determine that the comfort measures are appropriate for the individual, the first step would then to be obtain a referral to hospice services and to obtain an out-of-hospital DNR order, which is that purple form we were just discussing. Once the individual has received the out-of-hospital DNR and has been admitted to the hospice services, the notification process for the DMH non-hospital DNR can begin. Next slide, please. So your individual is receiving hospice services and has an active out-of-hospital DNR. DMH will need to be notified of the individual's eligibility for the DMH non-hospital DNR. The out-of-hospital DNR and the hospice services notification form can be located on our website. The link is there on the slide. It was supposed to be, yes, it's right there. Once the individual has become eligible, Section 1 will be completed by the provider. So whether that be you or the program manager or the Q or the DDP, whatever we're calling them today, and then submitted to your local regional office designee. In Springfield, that will be Terry Kane. Ashley, who is it in Joplin?
It will just be the quality programs RNs for the Joplin area.
And you'll need to have that notification in within the first 24 hours of eligibility. Section 2 will be completed by the regional office designee and then forwarded on to the division's director or their designee and the DMH chief medical director or their designee within 2 days.
As the providers, the direct support professionals will not perform those life-saving interventions as long as we have all that stuff in place. They will not provide the CPR. However, a DNR does not mean we do not treat them. DSPs will still be expected to provide all prescribed comfort measures and respond appropriately in emergency situations. Like Monica was mentioning, you know, if something happens and we need to seek that emergency care, we should still be working on doing that within the individual or their guardian's wishes. As the Oversight RN, you will be collaborating with hospice services when those are in place on the individual's care needs. You'll, again, as always, provide education to the direct support staff and to any other team members working with the individual on their care needs. It's also important for you to help foster that communication with the whole team, the direct support staff, the individual, their guardian, all of the different representatives that step into their life at this time. Again, you're a really important advocate, especially as we're approaching their end of life cares.
So then in the event that your individual no longer meets the criteria for the non-hospital DMH DNR, that would be like they have been discharged from hospice or their out-of-hospital DNR is no longer active. Then you would need to you would fill out section 3 of the notification form. Again, that form is located on the DMH website. You would need to submit the completed form to the local regional office within the 24 hours of loss of eligibility. So if they were discharged today, by the end of business day tomorrow, you would need to have that rescinded form turned into the local regional office. Again, the local regional office would then forward that on to the director and the chief medical director. You will also need to notify the service coordinator whether when a DNR, non-hospital DNR, is either put into place or rescinded so that they can make the appropriate adjustments to the ISP.
Once the non-hospital DMH DNR has been rescinded, ensure all the staff are aware that it's no longer applicable. Ensure all DSPs understand that they will be responsible for providing CPR or any other life-sustaining interventions that the individual needs. And ensure that if there were any postings around the home stating that the individual was on DNR status, that those are removed, taken down, that everybody is fully aware of what is going on. And another important piece for you as the Oversight RNs is to continue to assess the individual and be that advocate if they were to need to go back into hospice services, or if there is if their health increases, or if we see a decline in their health status.
So this is for those individuals, this particular one is for those individuals that do not have the out-of-hospital DNR or hospice services. Supplemental documentation generally consists of a weight log for the previous 6 months, Oversight RN documentation discussing a decline in health, physician notes, appointments, physician notes and appointment notes showing a decline in health status, those kinds of things. Staff are responsible for providing CPR until approval from the chief medical director is received in the home. Again, the service coordinator is responsible for providing all the documentation to the chief medical officer and providing notification to the team members once it's been approved or it's been declined. At this point in time, I don't know that there's really ever a situation that we've had to go this route. Most generally, our individuals meet that criteria for hospice services and end up with the out-of-hospital DNR. So this is a process to go about if you feel like the client's health status is such that performing CPR, again, would cause more harm than good. The statement of terminal condition is one that this form needs to be filled out. Again, it can be found on our DMH website. It's a 2-page document and has to be filled out and signed by a physician. It's to ensure that all the pertinent information is provided before you submit everything to the regional office designee. It also is included into the information that needs to be sent off to the chief medical director so that they can make their determining decision whether to approve or deny the non-hospital DMH DNR.
Again, with this other type of DMH DNR, where hospice services are not in place, the direct support professionals will not perform those life-saving interventions like CPR once they have received that approval, once we get back to you all about that it has been approved by the DMH chief medical director. The direct support professionals will continue to provide those comfort measures. Again, just because the DNR is in place does not mean we are not going to treat and care for these individuals. As the Oversight RN, your role is even more important since there isn't the hospice nurse to kind of fall back on. So continue to provide that education, provide the support to the direct support professionals, and keep great documentation like you all do to support the reassessment of the DNR status, since that has to occur every 6 months.
This is the directive 3.120 is the directive regarding the DNR, the DMH DNR status. So this is basically to ensure that the actions, orders, and treatments prescribed and or provided to the individual by the contracted providers will not cause harm to the individual or hasten their death. So remember, our goal is to rehabilitate if at all possible. It is not to hasten someone into the end of life process. So in accordance to the department's statutory mission to habilitate, treat, rehabilitate the individuals served in the division, and the DMH contractors shall not withhold or withdraw food, hydration, antibiotics, or anti-seizure medications for the purpose of ending life. Psychotropic drugs essential to the treatment of mental illness that are otherwise authorized by law or department rule. Any medications, medical procedures, or intervention that, in the opinion of the medical staff, is necessary to prevent the suicide of an individual.
And in the event that you are going through this non-hospital DMH DNR process and it gets to the chief medical director, and they deny it, an appeal can be filed. The individual and their legal representative can contact the chief medical director within 30 days of receipt of the denial. Additional instructions, requests for information, and additional discussion will be handled by the Office of the DMH Chief Medical Director and their designee. Their information is up there. In conclusion, the end of life can be a really stressful and traumatic event. Our responsibility is ensuring dignity, support, and comfort for the individual by establishing clear and concise end-of-life care instructions, which can alleviate some of the fear, stress, and uncertainty for the individual and those caring for them during this time. And that is all we have.
Thank you very much. We appreciate you, ladies. And if anybody has any questions, comments, concerns, please drop in the chat, and we will include those with our question and answer document that we will post along with this recorded webinar. And so I am going to hopefully show, I've got the presentation here, the folder, I suppose you might say. We have our next guest available. Give me just a second here. I have trouble talking and trying to do things at the same time. Let's see, as you guys have probably noticed. Okay. All right, this is exciting. This is just stuff that I just think that we can't talk about enough. And I kind of matched these ladies together because they do work hand in hand related to assistive technology and just all the benefits that can be utilized through assistive technology just to help people be more independent and give them more control over their lives. So our next guest who will be speaking, I'm sorry, I got to scroll down a little bit, is Shannon Shore. She will be demonstrating a medication dispensing device called Spencer. Shannon is a sales executive from PAG4U Inc., which is corporation is contracted to work with the division. And then we do have another colleague who will be joining us, and she will talk a little bit more about assistive technology. And I'm just going to go ahead and introduce her as well. Her name is Holly Rife, and she is our division's provider relations specialist, and she is one of our state leads in assistive technology. And I'm so excited for you all to hear what these ladies have to say. So I'm going to stop sharing my screen, and Shannon, I'm going to make you the presenter if that sounds okay.
It does sound okay. Can you hear me all right?
Yeah, you sound great.
Thank you. It's been a rough morning. Only my child can cut his eyeball with his school ID playing Gaga ball. So when you said
that sounds wild. I'm so sorry.
It's a little past 2. I'm like, no, I like being here talking with you guys about Spencer. It's the best part of today. Well, Leslie, thank you for having me and your continued support with Spencer and the PAG4U technology. Leslie has been a great champ and cheerleader for us. And I hope too, once you hear it, you're just as excited as Leslie about what Spencer and the Pack for You technology can do for the individuals that you serve. So as she said, my name is Shannon Shores. I'm with Pack for You. I joined them last October. I've almost been with the company for a whole year. And they brought me in when they were contracted with the division so we could bring this through the waiver services. And why I was so excited is because 13 years ago, I was the vice president at Touchpoint Autism Services. So I had residential, day treatment, and employment programs. And I can tell you 13 years ago, the #1 medication error that we had was failure to administer. And it wasn't because just of a meh, we just don't want to give meds, right? The life of a DSP can be very difficult, or as a parent, as a caregiver, as a nurse, whoever that can be, there can be a lot of tasks. And medication management can fall down in those list of tasks. Even think about ourselves. When you have a medication or vitamins or things like that, we have a difficult time with medication. Technology is there for everything. We have alarms, we have alerts, we have planners. So why not add technology to medication administration? So when they introduced me to Spencer, I said, I have to be Spencer's pal. So really, I'm a sales executive. They gave me that title, which sounds a little bit too meh. But what I like really is that I'm Spencer's sidekick. He's not my sidekick. I'm his sidekick, and I am really excited to show you what he can do. The first thing I want to show here real quick is how medications are managed. This would be like a week's worth of medication. So what's nice about this is that, 13 years ago, we would have the nurse in the corner who's now trying to organize all the different medications for the houses and things like that and transporting them to the houses. And error can happen. Think about all the time that's wasted. And imagine in a great world that all that time is taken out of this and put into a simple box. And this is the reality. So let's say we're working with Mary Smith, and Mary Smith is working with Pack for You. Maybe she lives in a group home. This means that, they've identified this service for her. Her support coordinator has added this to her plan. It's got to, the approval's been there. We come out, we train on this, and then every 2 weeks, Mary's going to get a box. Let's just say to her home. That DSP or that nurse, whoever that contact is going to open that box and going to pull out the medications. The medications are already in here. This is 1 week's worth of medication. But Shannon, I can't see in this box. I'm taking out the control. How do I know this is in here? Well, that's the cool thing about the Spencer and the Pack for You technology. This is packed with Parata technology. So what that means to you is that Spencer is FDA approved. He gets it right 99.98% of the time. He does that because of all the different steps we take to package this. He also lives in the cloud, which those orders will go with the technology to double, triple, quadruple check what's in this box. So he gets it right 99.98% of the time. So Shannon, how does he get it wrong that 0.02% of the time? Well, because Spencer can do all continuous meds, including supplements or vitamins. Well, we know some supplements or vitamins can be rather large. So the error that he's going to make 0.02% of the time is that he may squash a pill coming through, but he's only getting that about 0.02% of the time. So he gets it right quite a lot. A couple other things about this is that on the front of the box here, it's going to have the name, it's going to have the date. Let's just say Mary takes a lot of meds, and guess what? 1 week's meds are not going to fit in this, so she may have 2 boxes for the week. So this will say 1 of 2, and the other box will say 2 of 2, so it's very clear which box goes in first. You also see a QR code in there, because this will help there that we can't see in this box, right? Because what if Mary is roommates with Susan, and Susan also uses a Spencer device? Well, what happens if I get busy, open that box, I'm paying attention, and I drop this in the wrong container? This is the QR code goes to this Spencer, so I can't mix them up. It's going to air out. So there's no way to be passing the wrong medications to the wrong person. So we've already saved time. We're going to drop it in.
Your medications are low. Thanks for your patience.
So as you can see, Spencer also has a voice if I were the creator of Spencer, I'd make it a little sweeter, cuter voice. I just don't think it matches him, but maybe one day they'll ask me about Spencer's voice. So right now, Spencer's connecting to the cloud. So those medications that are in the box, he's, going to connect that to the cloud, where in the cloud lives the pharmacy, any of the doctors, the agency, maybe a support team, maybe the guardians. Each Spencer is for really the needs of the person. So someone's program might look completely different. Susan's looks completely different than Mary's because who that team looks, who that team is and what they need. So he's connecting with the cloud. He's connecting with the pharmacy. So our pharmacy, you have to use a Spencer certified pharmacy because of the technology and how it's loaded. Right now, we're working with Integrity Pharmacy out of Springfield, Missouri. They do cover the entire state of Missouri. So if you do have that agency that says, I absolutely love my pharmacy, because if you had a bad pharmacy, when you have a good one, when you have a good one, right? And that's a little bit of traumatizing to go, do I want to switch a pharmacy? We can talk with those pharmacies about becoming Spencer certified. And if you have those pharmacies that you're thinking of, refer them to me. Email or my cell phone number. I would be more than happy to talk about becoming a partner. But right now, to answer that question, it would be about the Spencer would be using Integrity Pharmacy. And so it's connecting with the cloud with Integrity to get those orders. And so on the screen here, it has the date, it has the time, and it's personalized. Hey, Mary, your next dose is at 2:17 p.m. So say Mary lives maybe in an apartment and she's learning to take her medication more independently. Maybe that's her outcome. It'd be great if this could sit out because it gives her that prediction of when it's going to be her next dose. And Spencer's going to let Mary know by giving a chime or just a little prompt there that it's time to take her medication. And I'm going to ignore that prompt so you can hear him come on, and he will tell you that it's time to take your medication.
It's time for your medications. Press the blue button to dispense the next pack.
We're really starting to think about him and I. That worked out well, Spencer. So he's a very persistent little dude. So he'll continue to get louder and louder and louder and louder until Mary takes her medication. See, he's persistent. And so Mary will come over, or her staff will come over, because so maybe Mary is using her staff to become independent, or maybe this is in a group home where Mary will never learn how to use her Spencer, but maybe there's an outcome of reducing medication errors to decrease seizures or something like that. So whoever would be, come over and touch the screen, and it's going to dispense that medication. You know when you go to the pharmacy and the pharmacy gives you that stack of paper that usually no one reads? Well, one of the things that can happen is if there's really some details that we need to know about this certain medication, it's going to be printed here. So this one says, take with food or milk. Another example screen we can have on here are you having any problems with medication? Yes, I am having problems with medication. Why that's important is because all of these outcomes and prompts are monitored by a team of pharmacists at Pack for You. Because what we realize about med adherence is that when you start to go a little yucky or you don't like a medication, that's a reason for you to quit taking it a lot of times. So we want to intervene when we start to see these responses to figure out what's going on. Because it could be something as simple as didn't take it with milk or didn't take it with toast and feels kind of nauseated. So we want to step in as much as possible so we can continue to take those medications as directed. The other screens it could have on there, maybe it's going to be a pain index. Maybe someone's on a pain medication and you want to get an index on that. Maybe they're taking antidepressants and you want to do a depression screening. We can put lots of different screenings in there and gather that information. A couple things about this pack. This pack here, it's sealed. This is a pillow pack. It's in strip packing. If you've seen a lot of pharmacies are going to this because they're seeing less error, so strip packing. So this is taking strip packing to a whole new level. But it's going to have the time. It's going to have the person's name, the date, and it's going to list all the medications. This can hold up to about 5 medications in here. So let's say Mary takes in the morning 8 medications. Same thing as the box. This will come out, 2 things that come out. It'll say 1 of 2, 2 of 2. Couple QR codes here. One QR code. This is the right box, the right person. This one says, is this the right dose? Is this the right medication? So it goes into that box back to those orders to say, is this the right time? For some reason, we know medication sometimes can grow legs and walk away, and it's hard to prove or figure out what time that happened or what's going on. If someone would open this lid and tear out the next medication, when it goes to feed through and read that QR code, it's going to say, that's the wrong medication, and send alert to everyone in the cloud that Spencer's been messed with, which is very helpful. I see a question there about, can you put controlled substances in Spencer? You can put controlled substances in Spencer. You can't put narcotics in Spencer. That is, we put narcotics in Spencer in other states. That is a Missouri reg that the narcs will have to be outside of Spencer, but they would be packaged in a strip packaging box that would be numbered. So you could see at a glance what number you are with those narcotics. But any other controls would be in here as well. Because this is locked here. You also can add a 4-digit code to this because you saw how easy it was for me to dispense it. Maybe because there's a controlled substance in here, or maybe, you have this out trying to teach independence and you don't want a roommate to mess with it because it was so easy. You can put a 4-digit code. So when it alerts, you hit the 4-digit code and out it comes. Spencer also has Bluetooth capabilities. So let's talk about his technology. One of the biggest things about connecting people with technology is the internet. Wi-Fi still is a problem in some areas. Spencer has his own cellular backbone, so he doesn't need Wi-Fi. So as soon as he's plugged in, he connects to the cellular network in the area. Now, I know cellular, sometimes it can be really sketchy, but we started Spencer in the States 4 years ago in Tennessee. And even though Missouri can be rather rural areas, Tennessee has much more rural areas and we don't have a problem with that. He also has a 4-hour battery backup. If he loses power, this will pop and you can get into that medication if need be. And also too, I have these squirrel moments. I have to turn off this chat because it's like squirrel looking at what they're saying next. But he does have Bluetooth capabilities with all that technology. So say someone is taking any blood pressure or any other vitals or weight management or maybe temperatures, we can put in orders here that it's time to take your blood pressure. This is actually saying don't forget to take your blood pressure, but we can put in an order there where they push the button, put on the Bluetooth device, blood pressure cuff, and now that reading goes right into the cloud where whoever's on that cloud team could log in and see what those vitals are in real time. Also, too, that adherence or non-adherence with that medication is also in that cloud. So that leads me to the next thing. The other really cool feature that Spencer does is telehealth. So can you imagine now if a doctor had to do a visit, you could connect, there's a screen here, or the screen's here clearly, but the camera's here. You can connect with your doctor to do telehealth visits. Your doctor could log in or you could send the information beforehand that's going to show maybe the past 30 days of adherence or non-adherence along with those vitals. So now we're making real-time health decisions with real-time information. We also recently partnered with Station MD. So they're going to be getting a training on how to use kind of our platform, all their doctors. So it'd be nice that, if folks are using Spencer and also have Station MD, which is they're both assistive technology, great to put in the plan together. They can log in and see what's going on with their adherence or non-adherence because 40% of all Station MD's calls are medication related. So to actually have this information is priceless to them. Also, too, Spencer's cute and all, but no one would want to take him to lunch or to a job. So what we can do is meds on the go. I met with a young man last week who has a job, wants to be more independent with medication because he wants to move out to his own apartment. So what we really like is we can do meds on the go. So let's say I'm missing my noon med. I would go into meds on the go. I'm going to miss one. I hit yes. Now that is put into the cloud as meds on the go. He's also going to download our app to his phone. And so it will serve as an alert. It will serve his Spencer away from Spencer when he's at work. So he'll get the notice that it's time to take his medication and he'll take his medication. There's also an app for family members, guardians, those loved ones, those ones who always want that information, right? And they want up-to-date information. Now they won't have to call you. Then they can get this information if it deems appropriate about adherence or non-adherence, how they're doing, and also to the current med list. So if they go to the doctor with their loved one, they'll actually have a current med list versus what are they taking? What got discontinued? And speaking of that, one of the biggest questions sometimes is, okay, Shannon, that's great. That box looks really handy, but what happens if there's a med change? So if there's a med change, let's say that's the reason why we like to do it every 2 weeks, because if we do it every month, we're going to be wasting a lot of medications if there's a med change, right? Because there's like one place for Spencer to go in here, right? The box to go in here. So there's no way to say exclude this pill. So say that Mary goes to the doctor on Thursday, and on Monday she's getting her new box, and the doctor wants to add a med. The pharmacy is going to reach out and see if we can add it on Monday, and a lot of times they say yes, that's fine. Just happened to see her on Thursday because that was her appointment. If for some reason the doctor says nope, I need for her to have it now, of course her Monday box will have that, but we're going to put a screen in here, and I'm going to send you. If Leslie doesn't have it, I'll send her the presentation that will actually have some slides that you can see this where it says Dr. So-and-so has added, however milligrams of this medicine, and it gives an alert to take it. Because you might have like a separate vial for Friday, Saturday, Sunday in there, but all those prompts can be in here and those reminders can be in here, but it has to be outside of that because this box is already packaged for her regular meds. But her new box would have that new med in it. Now with discontinued medication, same thing. If we have to discontinue right away, we put alerts in here that when you get to this pill, make sure that you waste that medication. For some reason, and I call this a unicorn moment because it doesn't happen often, but if for some reason you did not feel safe about that medication and then wasting it, we pick up that box and give you, the remainder of a new box. So that if there was any safety reason, we would take care of that. But most of the time, through the prompts or waiting to that next bill takes care of a lot of those situations. Okay, I have a few questions here, and I want to give time for Holly because Holly makes this all come together. Okay, so dispense. Yep, I answered that about the controlled substances. Kristen said, would you need a different machine for each patient? Yes, one dispenser, one person. And so they'd be labeled on the side on there. And like I said, that QR code on the box would ensure that you couldn't mix up any medications. And of course, their name would be here on the front too. Mary, Susan, whoever that would be. Can multiple boxes fit in one dispenser? Nope. One box in here. And I'm gonna step outside the lines here and say maybe Kristen's also thinking about maybe PRN medication because PRNs come up a lot too. Because it is just one box that goes into the tub of dispenser, which is continuous meds. So if it is PRN, let's say if it's, a cream that they take, they put on, twice a week, or a vitamin supplement, we can put those orders and prompts in here, but that medication will still come from the pharmacy. When we still can deliver all of that, we can refill all of that, because that's one of the biggest issues I hear from agencies is refills, that they sometimes don't say med compliant because it's hard to get those refills coming in. Integrity Pharmacy will take care of that as that pharmacy of record to ensure all the medications are there, including PRNs. But we could add that in here as well, but those PRNs would be separate.
And it looks like Holly has joined. Oh, sorry. Did you want to address another question? It looks like Holly's on now. Hi, Holly. All right. I think
You're muted,
she's
Holly.
there. You're muted, our dear, our guru, our assistive technology guru.
Well, as I will do a handoff to Holly. I think I answered the questions there. But there's a lot of information about Spencer in a short amount of time. But what Holly is going to do is tell you that how this gets covered and how to use Spencer with squirrel moment with the individuals that you guys are serving. So Thanks, Holly.
Hi guys. I don't know why, but for some reason my PowerPoint's doing this weird. I can't find presenter mode. So, we
Holly,
will
can I help
just.
you? Do you want me to help you with that? I have a copy of it, or I'd be
I
glad to
can
do. Oh, sorry, go
I
ahead.
can share. I was just trying to find the mode where like it showed up big, and it also like showed me.
Oh, go up to the very top and where you see that little save guy, the CD-ROM that we don't use anymore. I think if you
Yeah.
click on the projector above home, it might help. It might do it. The projector
This guy.
over by the yeah. And if it doesn't, then I don't know what to do.
Well, it's okay. We'll wing it, and I'll have to, as always, if anyone would like more information about assistive technology or has any questions, please reach out to me at either email address, hollyrife@dmh.mo.gov, or you can contact our Universal Design and Assistive Technology team. We like to call ourselves UDAT for short. And that's this very long email right here, that technology first and universal design at dmh.mo.gov. And I'll have Leslie, if you don't mind dropping that in the chat for me, I would really appreciate it. So who am I? I'm Holly Rife. I am with the UDAT team on the provider relations team for DMH-DD. And I work with promoting and supporting and encouraging the use of technology services. So, okay. So Missouri is a technology first state. And what that means is that when we look at supporting individuals, we should always look to see what type of services can be supported through technology. So basically looking at the person's outcome and saying, okay, the person would like more independence with medication administration. So do we have a technology that can support them meet their goal? And you guys just saw Spencer. So that would be one way to do that. In 2019, we had a goal of surveying 1,600 people by the end of 2021. We didn't quite meet that goal. We're currently at around 363 folks. So we still got a long ways to go to meet our original goal for the Technology First initiative. And we're still moving forward. We've had some great progress since it was designed, and we're hoping to continue moving those efforts forward. Technology First is designed specifically to meet individuals' life goals, to increase independence, self-determination, and self-efficacy. Technology is a part of our everyday daily life. And we want to make sure that everyone has the opportunity to use those tools, because for us, it makes it really easy to join these calls and have these great meetings. But for someone else, it could make their life possible. It could give them employment where employment wasn't available before. It could give them independence where independence wasn't available. And it can really increase community engagement and partnership. And it also provides what we like to call dignity of risk. And dignity of risk is something that we all take for granted every day. Every time we get behind the wheel of our car, every time we take a leap of faith, it's a dignity of risk. And we have the opportunity to risk, fall down, scrape our knees, and learn from those things. And sometimes we prohibit folks we support from being able to take those same risks and learning from them as well. And, sometimes you got to boil the pot dry a few times before you learn how to make that macaroni and cheese. So we provide technology services through assistive technology, remote support, and HAC, which is our health assessment and coordination services. Currently, we have 7 remote support providers. We have 3 medical and medication providers, and 1 application for task management and support. 4 PERS and MERS. So if you're not familiar with those acronyms, that's the personal emergency response and mobile emergency response. Think of those as really fancy help I've fallen and can't get up buttons. And then health assessment and coordination, which you guys probably are aware of as Station MD services. And all of those fall under the UDAT team. Health assessment and coordination is its own service definition from assistive technology. However, because of its telehealth and remote coordination, we've put it in with UDAT for that technical assistance and support piece. So some things to think about when you're thinking about assistive technology. Technology is not an either or service. It really is an and service. Someone would like to become more independent with communication and they still need live person support. Go for it. Some other great areas that overlap: employment and technology. A person really wants to be independent in their job, wants to have a job, but they need support, and they might need more support than what can be done with a live in-person coach there. Assistive technology does not require bids. It is provider choice, just like if you guys work for day programs or things like that. And then assistive technology is different from specialized medical equipment. We had a May UDAT Lunch and Learn that talked about the difference between specialized medical equipment, environmental adaptation and accessibility, and assistive technology, and how those three services are different. There's also information in the support coordination manual about how they're different. But when you think about SME, think lower tech stuff. The built-up spoon, those fun mats that you can put on your table and your bowl and cup and everything won't move, even if there's an earthquake. That's all SME. But the feeding robot, that's going to be assistive technology equipment. So what if you're working with someone and you think technology might be the best solution, but you don't really know what that's going to look like? You don't understand how that might be helpful. We do have 4 folks across the state who can provide an assistive technology consultation. The 3 of us on the UDAT team: Shelly Brown, Jason Elmore, and myself, as well as Chris Rodriguez from Missouri Inclusive Housing. And then Missouri Assistive Technology also does some consulting too. There are specific modifiers for each A9999 code, which is the assistive technology umbrella code. And I like to think of all the modifiers as like their favorite suit jacket or their favorite little dress. And I always ask people to please make sure that that A99 clothes is clothed in their favorite outfit before they go through UR. It's just an easy way to remember what all of the modifiers are. And there are 4, so it's kind of big. As I mentioned before, health assessment and coordination. It has a new guideline now. It's guideline number 86, and it provides guidance for the authorization. And that part of that authorization includes a 1-page addendum. Now, this service looks a little different from any other service we've ever done before. It can be used and then be authorized, which is completely different from any service we have. It is a subscription service, so it's 1 unit per month at $30 a month, whether that person doesn't call at all during the month or whether they call 3 times a day, every day of the month. It coordinates not only urgent and emergent care, but with primary care and specialists too, and it's available 24/7. So if you guys missed the MoDD and You webinar, Station MD spoke about how their services collaborate and bring together all of the healthcare circle of supports and how they can coordinate and facilitate care across the board. And even if a person's at their job site and they have a medical question, they can call Station MD through their smartphone in the break room or in the parking lot. So Station MD has been a great benefit for us. They started in the pandemic, but they are still available. They are now part of our approved waivers. And there's more information about them on our DMH website. They actually have a button on the homepage to learn more information about them. So we are seeing growth, and it is really exciting. There's been increased opportunity for conversation, collaboration, and learning opportunities. We are currently supporting a group of community providers who have integrated some technologies into their service delivery system, and we are meeting to talk about how we can grow the service in the future. We have our technology navigators who are supporting other support coordinators and TCMs to learn and have meaningful conversations about technology and technology supported outcomes. And I'm also working with UMKC to build up self-advocate group who can go talk with other families and really help people who are interested in technologies but not quite sure how to advocate for themselves to get the ball rolling there as well. So remote supports is currently part of our assistive technology definition. It is going to be moved out to its own definition. It does have its own modifier. It's a GT modifier. And some things to think about when you're looking at remote supports. Cameras can never ever be in any private areas of the home, which means bedrooms or bathrooms. They can never ever record audio or visual. And cameras don't mean the two-way video calls that we're doing right now. Cameras really do mean those surveillance type looking cameras that are turned on for very specific reasons. And they are to be off in the off position at all times, unless there's a very specific set of circumstances outlined in the ISP. They do require specific policy and data collection and approval to use remote support-based cameras do require division support. So if you have a community provider who's working to put some camera technologies into the home to support specific individuals' needs, I think I'm working with all of them right now to work through that process. But if you're not, if you're aware of some and they're not working with me, shoot them my way and we can work through those and make sure we're covering all the bases and supporting people without surveillancing them. So just some final resources and information to wrap up for today before I see a few questions in the chat box that I'll answer. DMH.mo.gov, our public-facing website, is a great way to get some information. We have a technology first page under information for support for case management providers. You'll find what we call the risk assessment. Now, this is not a risk assessment in the terms of, remote supports is too risky, or technology is too risky for this person. It's really an assessment of what's an individual skill level with using technologies, are their own personal skill levels, and where's the gap? How can we bridge it? Don't forget about our UDAT Lunch and Learns that are monthly, the second Tuesday of every month. The No Wrong Door series through UMKC and Missouri Assistive Technology is a great way to learn about everyday technologies that can support individuals. The Missouri Assistive Technology page has a bunch of resources on it. There's even a swap page on there for folks who are looking to swap out SME and other technologies. And then, of course, you can always reach out to the UDAT team for any additional support that you need. So that's all I had. Please define the acronyms. Let's see. I'm not sure which acronyms I used. So UDAT is Universal Design and Assistive Technology. It's the provider relations team that is focused on universal design and assistive technology. We mainly focus on all things assistive technology and then home modifications. HAC is our Health Assessment and Coordination Service, which is the service that is currently being supported by Station MD. They're currently our only provider of that service, and they are the ones who can coordinate all of the healthcare professionals to help support services. Assistive technology, I might have referred to it as AT. And that's our whole assistive technology service definition as outlined in the waiver. And Barb, if I missed any that you're still like, what in the heck did she say? Please drop it in the chat and I'll explain that one too.
And we appreciate you so much, Holly. Oh, sorry. Go ahead. I was just going to say we appreciate you so much. And also, attendees, if you don't mind putting it in chat for all panelists, and if we don't have time to get to your questions now, and if they do happen to be the little anagrams that we use or what have you, we will definitely put that on our Q&A that we're going to post with this webinar. So there is so much awesome stuff to this assistive technology, and I know you guys have a lot of questions. So maybe just another question, and then we do have one more small presentation we'd like to do prior to closing today, which is at 3. And I hate to cut you off, Holly, because this is just a neat new age and exciting stuff, and we really appreciate you having, spending your time with us this afternoon on such a beautiful day too.
I'm so happy you guys invited me. So Corinne, I think you're asking about Spencer, and you can reach out to Shannon and I. We can talk about how that works. And then the last one, SME, is specialized medical equipment. So thank you guys so much for having me. You guys have a wonderful afternoon.
Thank you, Holly. Appreciate you, and appreciate you too, Shannon. And Shannon Shores did put her email contact information in there. So if you are interested in Spencer, you just go ahead and reach out to her. And I did drop in chat the how to look more at Missouri's assistive technology. It's clear up in the, I'm trying to scroll up so I can re-put it in there, but we'll definitely post that along with our webinar. It'll be in the Q&A page, because we just want you guys to be able to support people and assist people with, being able to be more independent and just being able to live their life, live their best lives, right? That's all of our goals. I think I'm safe in saying. Now, without further ado, and I do apologize, I get carried away when I talk about the MODD Hearst project or process, excuse me, but that stands for the Missouri Division of Developmental Disabilities Health Risk Screening Tool process. And I want to do a PowerPoint, and I apologize, it may run over, but I sort of got carried away with the slides whenever I was preparing it. If you're not able to hang on past 3, we will have this as a recording, and it will be posted on our site. So you're more than welcome to look at the whole thing or stay on board. I'm going to really try to be mindful of your time, though, because I do not want to abuse the time that we have here. And I know you're all very busy, so I will try. I just don't want it to be like rushy, but I think we can get it covered fine. All right. So MODD Health Risk Screening Tool process, or you might hear project. The following presentation will provide you information for implementing the MODD Hearst project or process if you're an RN who is employed by a residential service provider agency. We are currently in implementation phase 1, in which residential service provider agencies can voluntarily begin implementing the Hearst process for residential waiver participants. You will be given information just during this last 15 minutes here about like an overview of the process itself, and then some items that Missouri has developed based on this screening tool. So I'm excited to talk with you guys about that. So what is the Hearst? As I said, it's the health risk screening tool. The Missouri, the MODD Hearst process has also designed standardized electronic health risk support plan templates in the MODD Hearst system. So you log on and you go in and you complete a screen within the computer system. This screen will help the interdisciplinary team with identification of implementation strategies to mitigate risk and improve health outcomes. The completion of the Hearst and any applicable health risk support plans will align with the individual's annual individualized support plan, or you might hear it called ISP meeting. Information entered into the MODD Hearst system will be accessible electronically to all identified team members, providing a more efficient and effective system for interdisciplinary team member communication and direct accessibility to identified health risk, planning, and service information. So the interdisciplinary team will have access to it, log into their computer, and everyone will be on the same page with the health risk supports and the needs of that individual served. This is just what we're trying to do, is provide a more efficient and effective process for ongoing monitoring. And then ultimate goal, right, is to ensure the individual's waiver participant health and welfare. The MODD HERS process is designed to have the individual to their fullest extent possible, and then their identified interdisciplinary team support team, such as perhaps they have family or friends who participate with them in their activities of daily living. Definitely a direct support professional in the residential setting who knows that individual well, and then you all, your registered nurses, you play an integral role in this whole process. You'll be driving the bus, so to speak, and completing this screening tool with that core team of the individual direct support professional, and then any caregivers or family that is able to assist with answering questions. And the HERS will be completed during the month of the scheduled ISP meeting, and that will assist with identification of any additional supports that individual might need. And they come out as health risk support plans, but we'll talk about that a little bit more. I wanted to give you an idea of what the screen looks like. They're divided into categories, and there's 22 rating items, where as an RN you'll log into the computer, into the database. It will ask you a series of yes or no questions, and you'll answer them, and it has a logic built into where it will populate scores for all 22 rating items. But as you can see on this screen, those are those 5 categories. Functional status has to, and we'll see in here in just a little bit, but functional status has to do with like eating, ambulating, transferring behaviors. It includes self-harm behavior, aggression. Physiological has to do with seizures and other disease processes that are quite common and that have a great deal of risk associated. Safety is another category, and that deals with injuries, hospitalizations, frequency of services. That has to do with the number of times a person needs to have those higher level medical services to help keep them stable and healthy. So each of the 22 rating items are scored 0 through 4, and it's all kind of balanced, and it has a logic built into it to where it will come up with a healthcare level for the individual. But each of the 22 rating items will either have a score from 0, anywhere from 0 to 4, which 4 has potentially life-threatening or life-defining issues or hospitalizations in the past year. And this does look over a 12-month period, like the previous 12-month period for the individual. And then you have the 0, which really no issue at all within that past calendar year. There are some things, though, that a person may go through that will stay on the screen because it's just such a high risk health issue. So that keeps our minds flagged and heightened to the fact that person could have something happen again. Because whenever someone has a bowel obstruction, they're bound to have another one. They're at high risk for that, and people can die from those things. If a person has a bleed in their digestive tract, that's another high risk. They're at a greater risk for developing another one. Also, a fracture during a transfer, that is also considered very high risk. And once you all begin implementing, you will have an in-depth training that will review these things in more detail. Now, this is what I was talking about when it comes to healthcare levels. The healthcare level is assigned upon completion of those 22 rating items. So once you submit that screen, the person will have a healthcare level. And healthcare levels identify the overall degree of risk for the individual. HRSA has been able to demonstrate that the healthcare levels are accurate predictors of lifespan and mortality. The identified healthcare level of 4 has been associated with the highest risk of unanticipated and unexpected deaths based upon available data. Your eyes aren't really on them all the time. They're going about life. They're doing fine. 3s have a moderate amount of risk. 4s have a high moderate amount of risk, and they kind of fly under the radar. You may not necessarily have your eyes on them all the time because, they're able to maintain homeostasis. They, haven't really been unstable with health or behavior for quite some time. Not to say that their underlying health conditions couldn't be stabilized quickly, but you're not honed in on them per se. Fives and sixes, those are the people with high medical needs that you're already probably thinking about. Okay, so that's why that I just found that so fascinating about the level 4. I just from whenever I was able to work out in the field and work with people, it's like, wow, that really rang a bell. Plus, I'm able to review mortality cases from across the state, and I just thought this is really going to be so helpful because there's so many cases where you see someone and you kind of read through the flow of events and you're like, oh my gosh, if we would have been attuned to that, oh, maybe something could have been done. I mean, hindsight's 2020, right? But I really feel strongly, I believe that this tool will help us to be able to identify that risk and just really make sure we're on top of our game. And I do have testimony from nurses who piloted it and who've been doing it for a while, who do say that it does help them keep on their game. So I just wanted you to know that too. Let's see. So who does the MODD-HERS process apply to? And it does apply to individuals receiving 1915C home and community-based waiver services. For RN raters, for your intents and purposes, those are the people with a comprehensive waiver, which is the only one that provides residential services. The other 3 waivers are community waiver, partnership for hope waiver, and then the Missouri Children with Developmental Disabilities, or MOKIDS. That's as an RN rater, you won't be rating those 3 individuals with those 3. So why is the division initiating the process? The process is designed to serve as support to ensure individual waiver participant health and welfare first and foremost. Information entered into the system, as I mentioned before, will be accessible to all identified team members, hopefully providing a more efficient and effective system for interdisciplinary team member communication, and just being able to directly access, electronically, what their risk factors are, what their risk plans are, documentation. The nurses will be doing their monthly documentation in this system when they implement this process. So it'll just be really, really handy to be able for team members to log in. There's also a message center, so you can also message different team members. Let's say, I like this example. Like, let's say I go to dehabilitation and I'm so sleepy and I can't stay awake and I had to sit down a lot and I was almost taking a nap. And so my dehabilitation support worker is like, oh, wow, Leslie's really tired today. So maybe he will send a message. I mean, this isn't required. I'm just saying this is just kind of one of the benefits of it. So maybe he's like, oh, well, maybe I better send a message to that, or in the message center to the provider agency, and so that they'll kind of be, know what's going on. And, maybe I started a new medication that's making me tired. Maybe I've got other things going on, but I can just see this really opening up paths of communication between all of the parties supporting the individual. Oh, this is exciting. Let's see, I've got a couple minutes. All right. I apologize, you guys, that this is running over. The health risk screening tool was created by a fellow intellectual and developmental disabilities nurse. She has been a nurse since 1977, and her name is Karen Green McGowan. She began her career in nursing in 1963 when she graduated from Methodist Hospital School of Nursing in Omaha, Nebraska. She was in the Air Force. Her career in the field of intellectual and developmental disabilities, she actually began her work at a state hospital school in Iowa. And I'm kind of skimming through this because I want to get to the meat and potatoes of what it actually is. I threw this slide in here because I wanted you to know that this was created by one of us, right? I think that's really exciting. And I had the honor of meeting her once, and she is just a real neat lady. So we'll talk more about the tool itself. So, what are Missouri's enhancements to this process? So, Karen Green McGowan developed the health risk screening tool, and the company Inelectability is they're the people behind that. Well, Missouri, we decided to take that and run with it. So, based upon the health risks that are identified, it will populate health risk support plans, we've already made templates for it to try to make it easy for them to be created. And it pretty much outlines what an individual needs in order to be supported and decrease risk. Like if let's say that I eat too quickly, I stuff food in my mouth, and I need cues to slow down, cues to drink between bites. That will just plainly say that. That will just plainly say that on these health risk support plans. We wanted to make them as simple as possible for the direct support professionals to be able to review them and not have to look through a large ISP with several pages, but they'll just get down to the meat and potatoes of how they need to support that person and have it just spelled out right there for them to review. There is a module included in it for nursing delegations. We surveyed the state operated programs nurses to find out commonly delegable tasks that the nurses did delegate. And because there's not a laundry list in Missouri, the only thing I think that appears is just like medication administration, right? So if it's all up to the nurse, and that's a whole other topic of discussion. However, we did use these templates just to make it easy. We contracted with a nurse to get the most latest and greatest information and steps and procedures for these different things. They can be modified and individualized, because we want everything to be individualized, but it's just sort of I would say a skeleton or that's not the right word, a framework for the nurse to work with. So they're not having to do all this research trying to find a topic. And there's also the capability of uploading already produced documents, like if it happens to be medical equipment or something. There is an enhanced training library in the system. So you will go through trainings whenever you start implementing. That will stay in your training library, and you can go back and refer to them. And periodically, we will probably pop more different training opportunities in there that can help enhance your practice and your interaction with the MODD HRST system. We're starting to work more with incorporating person-centered thinking with all of this, because if we're sitting here helping people plan for their supports, we need to be person-centered, don't we? And as a nurse, I'm always like, you shouldn't be doing that. It isn't good for you. But you know what? If someone was doing that to me, I'd be a little upset. We all should be able to do what makes us happy. And yeah, we're here to support each other and keep each other happy and healthy. But the people that we support also need to, have choice and be able to make decisions. And which ties into what Caitlin spoke about this morning, if you were able to hear her. There is an expanded clinical reviews portion where the regional office RN. Okay, HRST is going to replace the HIPS process. So the regional office RN, instead of doing the HIPS nursing reviews on those that score 30 or over, the regional office RN who's assigned will complete an expanded clinical review on those that score 4 or higher, or if they their healthcare level increases by a certain amount. And that is really, it's similar to the HIPS nursing review. I'll just kind of compare it to that. It isn't exact, but they're going to do a little bit of a deeper dive and look into things and, just be that extra set of eyes and that look behind. So we are initiating the process. As I said, right now it's voluntary for residential service providers to implement, and you'll just start screening people as their ISP planning months come along. But of course, prior to that, there are several steps in the process for you to be able to get access to that. So far, our go live date is in 2023. It was tentatively in May of 2023, and we were aligning that with Connection. So far, I have not heard anything different, but you know how kind of sometimes dates get tweaked here and there. But anyway, right now, you all are encouraged. You and your agencies are encouraged to go ahead and join now. However, it is not yet mandatory, but it will be next year. So everyone everyone who has a MoDD waiver, who's a waiver participant, should have their initial screen completed by May of 2024. So, and that is, like I said, that's nothing's been adjusted, but you know how you kind of say in government, kind of tentative in case something kind of changes, but that's what we're looking at. And so when should the HRSA be completed? As I said, it should be completed every year at the person's ISP planning month. And then there's also, you'll get this in your training too once you implement, but it'll also need to be updated if any of those 22 rating items change. Like God forbid, if I had maybe a stroke and I had to go to the hospital, and then I was not feeding myself as I used to, or just any of those items, if where I need more support, you as the RN would re-screen me just to make sure that you haven't missed anything, that all the supports are in place, and you'll be trained on what that looks like. And the training does occur, just FYI, it does occur in the system. I think I have another slide and I'll talk about, well, actually I do have another slide, but I'll talk about what that will look like for you whenever it's time for you to onboard. So how long does it take on average to enter information in for this screen? The screen itself, 30 to 45 minutes to enter the information. However, your initial screens that you complete may take a little bit longer because you're not going to be used to this system, and you're just going to be like, am I doing this right? And so it'll take a little longer, but you will, practice makes improvement. I don't want to say perfect because nobody's perfect, but it will, the more you do it, the easier it will get. And 30 to 45 minutes is about the average. Sometimes people with more complex health needs, they may take longer to, because, sometimes that just, you know how some people can just have so many different health issues in a 12-month period. So who enters the health risk screen information for the person? You as the RNs, the oversight RNs or community RNs, you are responsible to enter in that information, and you'll be known as the RN rater. Who should be present with you when you're doing the rating? I think this sounds pretty fun. You'll want the individual to be there with you, and they, encourage them to participate as best they can. I know not everyone's going to want to just love to sit there while you're doing all that, but it's about them, and so as much as the individual can participate is just wonderful. And then a direct support professional who knows them well. That way they can help answer activities of daily living type questions. Let's say they go to a rehabilitation program and there's a staff there that knows them really well, and they can kind of help answer some questions, at that type of setting. If the individual wants caregivers, friends, maybe their guardian, whomever they want, if they choose anyone extra, that's totally fine. But that core group is the RN rater, the direct support professional, and then the individual. So how does an agency receive access to the MoDD HRSA system? So each division contracted provider will be required to have at least one identified gatekeeper. And what that gatekeeper does is they take about it's no more than 30 minutes, but it's a training in the system. And then there's a help document also, and they will be in charge of getting access to staff and coworkers who need the access, or removing access, or we say deactivating their account. And then, like I said, that'll be a special training, and the gatekeeper and our division will work with that gatekeeper in the electability, and our gatekeeper will work with the agency gatekeeper in order to do that and get comfortable with that. And I'm going to go to the next slide. As I said, it's about a 30-minute training for the gatekeeper. And then how long is the training for the role of the RN rater? The HRSA online rater training and additional MoDD HRSA training tutorials can take on average of 8 to 10 hours total to complete. They are all online, and you can stop them and start them at any time, and it will pick up right where you left off. So you don't need to just sit there for all that time and, 8 to 10 hours all at once. You can break it up, definitely. And some of those trainings are documents and they're listed as 5 minutes, just because that's kind of just how they have it set on there. But you click on it and it pulls up the document for you to review. And I really recommend reviewing them and then going back and re-reviewing them, because we found through our pilot that the more information that we were able to give the RN raters up front, the better off they would be. So I really encourage you to, when you're reviewing those documents and things, don't hesitate to take notes. Don't hesitate to relook at things. They will stay in your training library, so you can always go back and look at them. Okay, I think I said everything there. So, and then what will your identified residential RN rater role have? What will you have access to? Well, you guys will be special. As RN raters, you will have full edit and view access, which you will be able to complete the health risk screening plan information, or excuse me, health risk screening tool information. You're the one that has access to create the health risk support plans, if applicable. You will be doing the monthly residential RN oversight documentation in the system. And then there is also a component, you can add the medications and diagnoses information for the screen and update it. We're exploring other avenues of having other people be able to keep track of that and update it, because I understand some people have LPNs, some people have like health managers and other personnel who take care of things of that nature anyway. So we are definitely working on that. It just sometimes things are a work in progress and take a little time, but that was a suggestion from the field and we're taking it. Let's see. So what is a health risk support plan? The MoDD process includes those standardized electronic health risk support plan templates in that system. And myself and a group of RNs, we had a work group, we worked and we made these templates and tried to think of all the different supports that a person might need for any of these health items. They can be individualized in any way, shape, or form. We were just trying to help make it easier for the RN rater and team to, oh yeah, that does apply. Oh yeah, that does apply. And you're just kind of checking boxes. And the ultimate goal is to have the boxes you checked be the only ones to print out. And then that's what you can use for training your direct support professionals or whomever it is that needs to know how to support that individual. And those health risk support plans will become a part of the individualized support plan, not embedded in it, but it'll be like an attachment to it. So when is the health risk support plan completed? So as I said earlier, whenever the screening tool is completed, or the HRST, it assigns a healthcare level to the individual, but also those 22 health and behavior related items, it will score those. So any of those rating items scoring a 3 or a 4, I don't know if you remember when I showed the thing that had the 0 through 4. So if they score 3 or higher, that will trigger the need for the team to complete those applicable health risk support plans for that rating item. And the individual and their team have the option to access and complete any specific health risk support plan for any rating items, even if they don't score a 3. If you're like, we could really use one for this, just because, everybody's different. It's not a cookie cutter type thing, right? So you always have that option. But the only ones that are required are those that score 3 or over. And let me see here. So the completed health risk support plans will serve as an attachment component of the healthy living section of the ISP and are to be used, as I said, as an educational resource, a training resource for those direct support professionals who are in there supporting that person to know how to keep them healthy and decrease the risk where it's identified. That's why it's also important to have that individual there and then the direct support professional who knows them well, because they can, they can speak up and say, yeah, that sounds great, or no, I don't agree with that, or, okay. So we talked about this a little bit, related to the HRST, the screening tool itself, but you know what? It's that same team who goes back to the table and looks at those health risk support plans. So you'll be doing your rating. and then you will make an appointment with that individual and that direct support professional, and then whomever the individual else wants. And you guys will review the health risk support plan information and take care of that as a team. So this is a piece that occurs after you complete your health risk screening tool, and it is called the HRSA clinical review process. And I wanted to bring that up because that is a very vital part of the process. So when the health risk screen information for a person has an identified healthcare level of 3 or above, this requires a HRSA clinical review. And then the HRSA screen is considered finalized or completed once the HRSA clinical reviewer has reviewed and agreed with that screen. And I know that sounds confusing, but our regional office nurses will act as the clinical reviewers, and they do a quality check on that screen, and they will give you feedback. Not that they know that person or individual any better, but they have special training. And let's say someone scores a 3 in eating. Well, why did I score a 3 in eating? So you as an RN rater, you'll get training for this, so don't worry, you'll get training for it. But you'll want to put a little note in there that says why I score a 3. Maybe I need someone to sit right there with me and just really sit there and just really cue me to not eat stuff my mouth with food because I'm such a choking risk. Whatever the case may be, just making sure that note supports that score based on the training that you all receive. And that takes a little bit to get used to it. So, this is a whole learning process. It probably sounds very overwhelming right now, but we recognize that we're all in it together. We're all learning a new process, and there is a learning curve. So all I got to say is practice makes improvement. I don't know. It just makes better, right? Nobody's perfect, and nobody's going to be perfect. But you know what? At first, it might be a little tough, but the more you do, the easier it's going to get, and you'll get more comfortable with it. So I know you guys can do this. It's just hard thinking about change. So who conducts the clinical review process? As I said, it's the regional office RNs, and that would be for you. Also, you will have a little bit of back and forth, and that's just part of the process. It's not any kind of I don't know how to say it, but it's just part of the process. It's just like that extra set of eyes do that quality check on that note, how they do their training. Okay. Now I'd like to talk about the oversight, and don't worry, I think I only have 2 more slides, so hopefully, okay, we're over. I am so sorry. I'll be succinct. Okay. So this module, the RN monthly oversight documentation module, it's in an electronic format, and the assigned residential RN rater in the system will be required to initiate and complete ongoing monthly documentation in that module. And you'll start that after you complete those health risk support plans. You'll that following month, you'll start documenting your monthlies in the system. And just to let you know, the requirements for what you document or that kind of guidance isn't changed. We just put it in a computer format so you can type in there and type in your assessments. We kind of beefed it up too, so you can have all kinds of areas in order to document about labs and meds and just like changes and stuff. And so you can really address all the different issues. So it's not a change in the requirement. It's just a change in the place where you're going to need to be documenting it. And we will work with you to figure out the most efficient way to do that, recognizing that many people have electronic health records that you're already utilizing and just all kinds of other components. So honestly, now is I encourage you to join whenever, as soon as you can, because we can really work through some of that stuff and get you all good and ready before it does become mandatory. However, if you're not ready yet, that's okay too. But I just want you to know that we are here to support you to be able to be efficient, effective, be able to do your jobs to the best of your abilities. And so you may be saying, where should I submit agency interest and participation? So residential service providers should submit the request and any questions pertaining to the MODD HRSA process to MODD HRSA project at dmh.mo.gov. And you guys, thank you for hanging with me. And if you could, if you know people who couldn't, we will have the recording posted. I apologize for running over. It looks like it's 3:19. I know your time's valuable. So appreciate all of you, everything you're doing out there, supporting individuals with IDD and supporting each other. If there's the website here. If you want to visit our website, we're in the process of enhancing our MODD HERS process website to have some more information on it as well. And thank you so much. I think we can go ahead and come to a close. I want to remind you that all questions that you